doctors said they were most afraid of was unable to be in two places at once. You can't be doing two things at once, being in a ward and covering A&E and being in theatre. But the other was not having enough time because of pressure, and they felt that was putting them at risk of mistakes. What's worse is over half of doctors said that when these mistakes occur, they feel they will be blamed rather than the systemic failing. Mistakes occur, they feel they will be blamed rather than the systemic failing. And BAME doctors feel much more, they report much more that they will be blamed. Only about 40% of doctors feel content to report medical error. That is flies in the face of all the recommendations from Francis Mid staffs and also from John Berwick. And BAME doctors are only half as likely to report patient safety concerns, because they are more likely to say that if they report those concerns, they will be blamed rather than addressing the issue. Bullying and harassment is a big issue in the NHS. 40% of doctors report bullying and harassment, but BAME doctors report it at twice the rate. And we know that this will affect doctors' mental health. The GMC did a very good work last year, commission work by Michael West, that showed doctors who are under pressure, emotional pressure, stress, anxiety, are between 45 to 63% more likely to make a medical error. So we must not forget that the impact of stress and anxiety, and which affects BAME doctors more, does affect their ability for clinical performance, but also their whole experience of the NHS. Is estimated to cost the NHS £2.3 billion from lost productivity, absenteeism, and so forth. Next slide. Now, during the COVID period, we have been, at the BMA, been doing regular tracker surveys. We've done about 10 tracker surveys, snapshot surveys, with thousands of doctors responding within 48 hours. And again, what it has shown is that culture in the NHS has worsened during the pandemic. Doctors are saying that there's greater bullying and harassment, and twice as many BAME doctors say that they're suffering that. Again, during the COVID pandemic, when there have been safety issues, PPE and other issues, BAME doctors have in particular said that they have not reported safety issues because they were worried, again, about career consequences and so forth. In terms of PPE itself, twice as many BAME doctors told us in the survey. In terms of PPE itself, twice as many BAME doctors told us in the survey they felt under pressure to see patients without proper protection compared to white counterparts. And again, far fewer BAME doctors felt they were properly protected as they were looking after patients who were potentially infectious. Next slide. Sorry, and I should just mention that in terms of risk assessments, we've got plenty of data that whilst risk assessments now are occurring, the majority of getting infected, becoming seriously ill, and even dying, and the risk of actually passing on infection to their loved ones and families when they came home. So that's been a huge stress, and of course, added to that, the lack of PPE has made many doctors, extremely frightened and anxious during the first peak. In our tracker surveys, we found that doctors told us, we had a mental health survey, we had 2,000 free text responses. What they said were issues around seeing so much death they'd never experienced in their lives before, and ill health. We had doctors, junior doctors, telling us what it felt like and how taxing it was emotionally to look after their own consultants who were training them in intensive care, to actually be holding smartphones and iPads on the beds of patients in their last days of life, so that they were the conduit of communication between visitors, because hospitals have had no visitors. None of us have worked in a health service without loved ones seeing patients, and that's what doctors have had to contend with. And they've also had the ethical dilemmas around how to manage if they don't feel adequate protection. The BMA continues to provide a 24-hour helpline for any BMA member who's facing an issue at work during the pandemic. We've increased our helpline to 24 hours a day. Next slide.
Sorry to interrupt, Dr. Nagpal. Due to time constraints, we may have to move to the next session, if that's okay, the next speaker.
We got,
okay.
Can you sum up in 30 seconds?
Okay, so okay, I'll try and finish. I think Lucy said her presentation was slightly shorter, but I'll try and finish. So mental health has worsened. Let's go to the next slide. Worsened during the pandemic. And doctors do not want to go back to the old normal. We did a big survey, and what doctors have said, they want an NHS where they have better use of technology. They actually do think some of remote technology, remote consultations works for patients and for them, and they want less regulation, and that's clearly stated here. Next slide. And they also want a collaborative NHS. Doctors have told us repeatedly in BMA services that the divisions between primary and secondary care are harming patients. 60% say harms patient care, and it also adds to an enormous doctor workload as we duplicate things. And during the COVID pandemic, and now trying to clear the backlog, we certainly do need to address the obstructions that patients and doctors face between the sectors in the NHS. Next slide. And this is the final slide. So what are we calling for as a BMA? We're saying that the NHS has to be properly resourced. You can't just carry on with fewer doctors, fewer beds, community facilities and so forth. And that needs to be given whatever it needs, in the words of Rishi Sunak. We have to sort out this backlog that I talked about. It's a serious issue affecting patients. We must invest in well-being, because investing in well-being, as I said earlier, is investing in patient safety. Doctors cannot be safe if they're burnt out and stressed. And we have to look after our staff. We must address public health doctors and the fact they have been suffering enormous disadvantages. The COVID pandemic has shown the importance of a proper public health service. And we need to dramatically, and we need to radically shift the culture in the NHS, a culture that must be driven by inclusion, equal opportunity, and one that is supportive of doctors. And we must finally break down the boundaries between primary and secondary care, so that all of us as doctors can work as one profession and one team, all on the same side. So thank you very much for listening. Sorry, I was a little bit ran over. Thank you very much for listening, and over to Lucy. Thank you very much.
Thanks very much, Sean. I think that was really excellent, and it really segues well into the next speaker, because you were talking about all the mental health issues that we were facing during the pandemic. So next we have Lucy Warner. She's the Chief Exec of the NHS Practitioner Health Service. Lucy has had over 25 years of experience in the NHS and has previously worked at NHS England as a person responding to concerns leads and focusing on the concerns of the medical workforce. So Lucy, without further ado, I'd like to welcome you to talk about the impact of on the mental health of this pandemic. Thank you very much.
Thank you so much. And apologies from Dame Claire Gerarda, who really wanted to be here today and is sorry that she wasn't able to be. So for anyone who isn't aware, NHS Practitioner Health is the makeup of that group. We have around 20% of those doctors were qualified overseas, and BAME doctors make up about 35% of that caseload. So it does feel like there's a somewhat over-representation in terms of the people who seek help with our service. I think those 10,000 who've come through our events, those 5,000 doctors that we're currently treating, have really given us an opportunity to understand how people have been feeling over the last 9 months or so. And as Chan so elegantly put it, we were already in a mess before. People were already struggling. They were already finding things challenging. But really, over the last 9 months, people's emotions have been going through a range of turmoil and different issues at different times. So starting early on, what we saw back in April time was really some new issues started emerging. And we started to hear people saying, I'm being bullied. I've got difficulties with my workload. I'm struggling. Line managers saying how stressed they were and that they didn't know how to manage what was being asked of them and the pressures that were being placed on them. And lots of mentions around a toxic environment. And at that time, we saw a peak of BAME doctors registering with our service. They were making up at least 40% of registrations in June. So there was a real issue, I think, and picking up on the point that Chan was making so elegantly again about doctors from BAME backgrounds. I think so elegantly again about doctors from BAME backgrounds identifying bullying, and that was certainly happening in June time. As we've moved into the late sea, at that time was lots of issues with fatigue, sleep, people saying they weren't able to sleep. And then what's perhaps slightly worrying was lots of issues around self-doubt and question. Next few months, with winter already here, the clapping has gone, the appreciation is waning from both the public and the politicians. And we've got this huge challenge in terms of delivering a vaccine programme to the population. These first signs of burnout, this fatigue, this exhaustion, this struggling is really a point of concern, I think, as we move forward. But I do want to end on a slightly more positive note and say the last few months have seen a massive focus on well-being. There's been loads of support put in at trust level, common rooms, webinars, even free donuts. There's been less at primary care, and I think we do really need to think about how we support colleagues working in primary care and making sure that they get the help and the same level of resources that are being put into secondary care. But there are things happening. There are wellbeing hubs being created in Scotland and across England. Wales has expanded its service. There's a service happening for Scottish workforce, which will be starting to deliver in December, and Practitioner Health will be delivering that at least for the next 6 months. So there's lots of support out there if people want it. And I hope that anyone kind of listening to this presentation this morning and thinks that they might be struggling or thinks that they know someone who's struggling, please do remember you're not alone. There's many, many, many of us feeling that way right now. And there's lots of support out there. So please call us, text us.
And thank you very much. Thanks, Masoon and Anupama, for keeping us online. Thank you.
Yeah, thank you.
Unmute yourself, Rahul.
Yeah, I said we are live, Dr. Chan. Please go ahead.
Yeah, thank you very much. I think this is a very, very important session. In our Indian culture, we call this is known as a guest lecture, more or less. And in our Indian culture, we say Atiti Devi, more or less. And in our Indian culture, we say Atiti Dev Bhava. That means the guest, the status of the guest is equivalent to God. So in a way, we are giving you that status, Baroness, today.
In May 2020, she was appointed by Health Secretary Mac Hancock to head NHS Test and Trace, established to track and help prevent spread of COVID-19 in England. In August 2020, after it was announced that Public Health England would be abolished, Harding was appointed interim chair of new National Institute of Health Protection. Remarkable achievements. Today we are truly fortunate to have you on the board, Baroness Hardings. Thank you for coming. And she'll be talking on fighting COVID. That's it from me. Thank you. Over to you.
Thank you so much. I hope everyone can hear me all right. And thank you so much for inviting me to speak at BAPIO. I'd like to start by saying and recognising the extraordinary work and contribution that BAPIO as an organisation, but all of your members and the broader BME community across the UK have put into the fight against COVID. And we know that contribution has been at some considerable cost. And I want to say thank you for the contribution that you're making to your communities, to your families, to our society, to our country. Months. And I thought I'd share mine and ask you to and encourage you to share yours as I speak. because I do think it's essential that we all keep learning. That's one of the fundamental pillars of a great health system, is that we create a learning culture, an inclusive, open, collaborative and learning culture. So we should embody that in hard times as well as in good ones, and that's how we get better. I wanted to talk about 4 broad things, themes of learning. The first one is the most general, and I've certainly learnt it in spades in the last 9 months, and the last 6 months, particularly in my role leading NHS Test and Trace, is how interconnected everything to do with improving and protecting public health is. It is the ultimate multidisciplinary, public, private, place-based endeavour. And it only really works when we all work together. And you all know that as experienced and senior clinicians, that the drivers of public health are so much broader actually than our health service alone. And I've certainly found in the last 9 months that we have worked together more broadly as a civic society in Britain than I think ever before. And that there has been much talk, which takes me to my second main theme, much talk in the NHS over the last 5 years about integrated care. Many papers written, many documents published about the importance of integrated care systems where local government, they come from the civil service in Whitehall and across all government departments. They come from a variety of different private sector providers. They come from the military. And we're all working together in an endeavour to break the chains of transmission. And we've discovered that we can work together really very well indeed. And actually, it only works at its very best when we work together with the general public, with everyone. We've also, and this is my third learning from the fight against COVID and how we create a more equitable and inclusive health service, is we need to build a human, ultimately human and digitally enabled the white British community. This is disproportionately affecting this country's ethnic minority communities. It's affecting it in infection rates, hugely sadly in mortality rates as well, and on the financial and emotional impact. So evidence I've seen would say that 45% of BME people report a significant negative financial impact on the crisis on them and their families, compared to 35% of the population as a whole. And there are similar measures when asked about people's emotional and mental well-being. So this is an extremely unequal disease, in that more of our BME friends and colleagues are acquiring the disease, having serious consequences from it. And even if you're not getting the disease yourself, you're more likely to be economically and socially disadvantaged as a result. So I think this is shining a light in our society like never before, and it is hugely important that we learn from this. I think we are learning. I think there are some really material changes that are happening on the ground in local communities, but we need to do much more of it. And the fight against COVID is one of the ways that we will make a change. The Secretary of State spoke this morning about the vaccine and his optimism around that. I'm optimistic in our fight against COVID, but I'm actually also optimistic that we are learning so much from this, and working together is the only answer to fight COVID and to create a more equal and more inclusive health service for the future. And if you take the system sits in a broader landscape of employment, housing, and community, we will make a significant difference together in the future. And I really look forward to working to trust the rules, to trust clinicians, trust our scientists. That's just at a very human, personal level. And I think you're completely right that we need.
Well, I am chairing the session mainly because this is a topic extremely close to my heart. And Ramesh allowed me to chair the session, actually co-chair the session with Mohsin. I have done a lot of work on racial equality, and that is probably why I have been asked to chair the session. So I'm going to give the mic to Moshi now to introduce the speakers.
Thank you, Dr. Matthews. I'm the second chair for this session. I'm going to quickly start with Professor Nishan to start off his first talk. He is the Vice Chair of Leicester University. And thank you, Dr. Nishan, if you can please start.
Thank you, Mashi. Good morning, everyone. It's nice to be here with you this morning. As introduced, I'm the Vice Chancellor at University of Leicester, and thank you to Biju and the organising committee asking me to say a few words. I've been at University of Leicester for a year. I started on the 4th of November last year, and then before that, I've been at University of Bristol for 25 years, and before that, I was at University of Cambridge for 7 years. And I'm originally from Sri Lanka, where I did all my. And I'm originally from Sri Lanka, where I did all my undergrad, high school until I came to the UK for my undergraduate. And I only have very short amount of time, so I want to talk to you about equality in higher education in the UK. And I'm really pleased that some of my colleagues like Kamalesh Kunti and Manish and others from Leicester are contributing to this conference as well. These studentships, on a typical year, they award 20,000 studentships. The number of black students or Asian students is much less. It's about 3%. And the black students is 1%. Now, clearly, that is a problem. We need to always, I'm very passionate about excellence. We should always reward excellence. But the problem is, if there is a 22% gap when you graduate, that will propagate in other parts of your life. So PhD, the minimum requirement is 2.1. So if there is 22% less, most of these students are not getting a 2.1. And if you put a criteria for PhD is 2.1, these students will not get a look in. And then if you then look at PUKRI, how competitive that is, and you need to get a first class to get one of these studentships. Clearly a student that is getting 22% less than a white student is seriously disadvantaged. So this is one of the things that I'm trying to tackle, is to make colleagues understand there is a significant issue facing higher education. On the one hand, we have created more opportunities, which is welcome, but we need to now deliver the outcome for these students. And there's a lot of work that is going on in Leicester and nationally and within Leicester. So for example, what I have said, and I looked at your program, and I'm very pleased that you're taking a holistic look at the differential attainment. That is exactly what we need to do. One aspect, the other is assessment. But even in assessment, it's not just the formal summative assessment. Let me give you a simple example. A lot of the work that we do within our student cohorts, particularly in STEM subjects, are group activity. But if you're the only ethnic minority in a STEM subjects, are group activity. But if you're the only ethnic minority in a group, you're immediately disadvantaged. So we need to look at how do we create these groups. So what I'm kind of asking everybody in the university and nationally to look at is to how do we create an environment in higher education sector that students, when they come in, they feel I belong here. I can achieve my full potential. Then we need to do what we need to do to kind of support them during that journey. So there are a number of things that we are doing in Leicester. I'm short of time. But I'm also very proud of our medical school and what they are doing. Recently, we got the Athena Swan Silver, which kind of demonstrates the work that we are doing on gender. But also recently, we signed the Bristol the Race Equality Charter. There is more work we need to do. But I think fundamentally what I wanted to share with you is that for me, it's a dereliction of duty if people like me in leadership don't fix this problem. Because as I said at the beginning, if it was female getting 22% and then not going on to do PhD.
Next slide, please. I first became gender aware when I got to senior levels in the college, and I wrote the first publication, I chaired the first publication called Women and Medicine, the Future. And the picture there is a picture from around 2009, where there are two women, myself and Dame Carol Black, one of the other female presidents of the College of Physicians, surrounded by men. Then if you roll forward to 2020, there's again a picture of me with some other medical Royal College presidents. And again, there's me, one woman, surrounded by men. So these two publications, both in 2009 and I hope in 2020, reflect the work that I've been doing on looking at gender in medicine. And the second one chimes very much with your title. We've called it Mend the Gap, not Mind the Gap. Can I have the next slide, please? So where are we now in medicine? In 1975, there was a Sex Discrimination Act, and it became illegal not to have equal numbers of men and women going into medical schools. Prior to that, medical schools had quotas for women. But now, 45% of hospital specialists are female. All specialties have more women than they did 10 years ago, and 77% of NHS employees are female, but only 44% of NHS chief executives in an organisation that has a predominantly female workforce. When I was discussing this with the then Secretary of State, Jeremy Hunt, he then asked me if I would chair the Gender Pay Gap Review in Medicine. So if I could move on to the next slide, please. To understand a gender pay gap, you need to recognise that it's different from equal pay. So equal pay has been enshrined in the law in our country since 1970. But a gender pay gap is the difference between the average hourly earnings of men and women expressed as the average hourly earnings of men and women expressed as a percentage of men's pay. Next slide, please. We set about doing a comprehensive and huge piece of work, which is the biggest review of gender pay gaps that has been done, we think probably in the world. We have a literature review. We did 30 interviews with men and women. We sent a survey to 40,000 doctors randomized from the GMC register and got hold of large quantitative data sets from the NHS electronic staff record, HESA data for higher education, tax data, which was mainly in relation to GP salaries, and also the which was mainly in relation to GP salaries, and also the UK Med database, which is about trainees. So overall, we had 83,000 hospital doctors and 16,000 GPs in our cohorts. And I'm going to just briefly go through some of it. And I'd like people to look at these really carefully, because what's come through in this work is that the issues that relate to gender pay are very likely to exist also for pay related to ethnicity. And we haven't looked at this properly yet, and we really, really need to. So can I have the next slide, please? So the literature showed that the issues around inequality in medicine have been around forever. People know about them. There have been 3 main reports. The one I mentioned in 2009, but also 2 reports that were set up by Professor Sir Liam Donaldson, who was the Chief Medical Officer at the time. But what we've shown is that legislation has been passed to try and change this and improve inequality, but change has been slow. So despite the Sex Discrimination Act in 1975, the Gender Equality Duty in 2006, and the Public Sector Equality Duty in 2010, not enough change has happened. So if I could have the next slide, please, and I'll show you some data. There has been a steady reduction in the gender pay gap since our first report in 2009, but it's still 16.8%, which is a very large pay gap for a single professional group. Looking at that in more detail in the next slide, please. Looking at that in more detail in the next slide, have different levels of gender pay gaps. And the bubble is the size of the professional group, and you can see the levels of the gender pay gap. And the prize for the big overall gender pay gap in medicine goes to, next slide, please, urology, followed closely by trauma and orthopedic surgery. And interestingly, the more gender balanced the specialty is, the lower the gender pay gap. So I want to just take you through quickly looking at that pay gap in a little bit more detail, which is shown in the next slide. So this slide is that 16.8% divided up into what contributes to that gap. Now don't worry about the small print, but look at the green bit. The green bit is where we can't find what contributes to the gap, and that's where actual discrimination come in. So if I contribute to the gap, and that's where actual discrimination come in. So if I look at the next slide, I'll tell you about the contributors to the gap. So they are that in general, men are older, they have more seniority in the in medicine, They're in particular special elections and now COVID. We were due to publish on several dates that have been taken over by news from other events, so it's still not out there. But we have 42 recommendations that we would really like to get out before the end of the year. The themes of these are to make senior jobs accessible and attractive to women, to address systematic barriers to progression of women, and that could also apply to minority ethnic groups, to increase the transparency around pay so we all know what each other are paid, but to introduce legislation that works and forces these changes through. There's a big piece about behaviour and cultural change, those so-called microaggressions towards people who are not white and male and don't automatically fit in to the medical workplace. We need also to look at clinical excellence awards and to reform clinical excellence awards so they don't get awarded just to what we might call the usual suspects. And we also need to build on pay gap research so that it applies to inequalities in other groups. I just want to look to the future for my next.
Here is Prof. Rao. She is an academic from Imperial College and she currently advises the NHS England for workforce and race equality. So without further ado, Prof. Rao, if you can kindly start your talk.
Thank you very much. Could I have my slides up, please? Well, perhaps while my slides are coming up, let me just start off by saying what a great pleasure it is to be giving this talk on this title that you've given me, Challenging Myths About Race Equality. I'd like to thank Dr. Matthew for giving me Challenging Myths About Race Equality. I'd like to thank Dr. Matthew, Dr. Zaman, Dr. Biju, Ramesh Mehta, and the moderators of this session for allowing me to share my perspectives on the myths of race equality and how we bust them. So could I have my slides up, please? Throughout their careers in the NHS, but show it. Professor Nishan was talking about differential attainment. Yes, differential attainment by ethnicity persists across all measures of career progression, the entire training pathway and all specialties. And it is for this reason that I set up a collaboration to develop the MRES, so the Medical Workforce Race Equality Indicators, and as a first step towards taking action on these inequalities, an induction program for international medical graduates. Now, just a few words about the MRES. I am proud of the fact that it's going to be a world first in monitoring race inequality at national level. And it'll be the first step to breaking down structural barriers to race equality because we know that evidence is powerful. And the intention is that it'll measure education and developmental opportunities and perform progression treatment by patients and employing organizations and also diversity in leadership. The aim is that it will be published annually starting with December this year and that data will be collected at national or regional or specialty level depending on what is appropriate for each indicator and at a pace best suited to each of the colleges, faculties or regions. Next slide, please. Next slide, please. May I have my next slide, please?
I think there might be an internet issue here because these slides show that you can't see them change.
Do you want me to speak without my slides? What's happening? Because I have internet problems at my end too. So, could I have my next slide?
Professor, the current slide's heading is the second myth: the international medical graduates can hit the ground running. Is that the slide you're talking about?
I have to say, can you all hear me? If you can, I'm just going to rattle on without my slides then. Well, the first of the
Perfect.
indicators will look at leadership. We know that Black and minority ethnic doctors are underrepresented in leadership roles, with about 17% of medical directors being made up of BME doctors versus about 36% at consultant level, and nearly half of the salaried hospital grade posts. We know, and Dame Jane has been talking about this, that Black and minority ethnic doctors earn less. The Asian men have been most successful in plugging and narrowing the ethnicity pay gap, leaving Black women doctors facing the largest pie for more consultant jobs, but are less likely to be shortlisted or to be offered a post. And I know that the Royal College of Physicians, under Dame Jane's leadership and now under Professor Goddard's leadership, are looking seriously at what the structural issues might be that lead to these dismal statistics. We know that BME doctors have more than double the rate of being referred to the GMC by an employer, and we know that they're more likely to have their repopulated with data, hopefully by the end of December. Now, the next lot of indicators are about differential attainment. We know that BME doctors are less likely to have their application to medical school accepted. I don't know what those data show in your medical school, Professor Nishan. Maybe we could discuss it later. They do less well in assessments as undergraduates and postgraduate trainees. For example, in one specialty, for postgraduate exams, the exam pass rate in 2019 was 69% for UK white trainees, 60% for UK BME trainees, and approximately 41% for international medical graduates. We also know from the NHS staff survey, if we extract doctor data, that Black and minority ethnic doctors report higher levels of bullying from staff and colleagues. They report lower levels of belief that their trust offers equal opportunities for career progression. They are more likely to report personal experience of discrimination at work, and they report fewer opportunities to contribute ideas and make changes at work, and how to innovate in resource-constrained circumstances. And despite all of this, it's very interesting that data consistently show that Black and minority ethnic doctors report higher levels of motivation and engagement at work. We know that they are underrepresented in national and roles, and that will be captured in the final indicators, which are 11A and 11B. Now, again, the Royal College of Physicians recently produced a report which highlighted that Black and minority ethnic physicians appeared to struggle, to access research in specific ways. And from their response to Black Lives Matter, the Wellcome Trust acknowledged that BME and especially Black applicants are less likely to be awarded Wellcome Trust research grants in the UK than white applicants. And we need to understand why that should be the case. The second myth I wanted to highlight today was that there's this view that international medical graduates can be recruited in Mumbai or Lagos and catapulted into our NHS hospitals, and they can simply hit the ground running. And yet what we do know is that they experience the worst levels of disadvantage. We know that a disproportionate number of deaths attributed to COVID-19 has been in BME staff. 95% of doctors who died belong to a BME background. And that the Public Health England review showed that historical racism and negative experiences of healthcare may be resulting in BME people being less likely to seek care when necessary. And when you translate that evidence to how doctors behave, they're less likely to speak up and demand PPE. And this treatment with indifference and the gap filler status that international medical graduates have had for so long must cease. The third myth is that there is no inequality in health research and health care. After all, we are the NHS and we are completely equal, are we not? Well, that isn't quite the case because there is a general lack of representation of BME people, for example, in research on older populations. And in recent times, you'll have all seen highlighted the paucity of BME representation in COVID vaccine research. We also know, and this is alarming, that algorithmic, when an organization values its minority staff, is a good barometer of how well patients are likely to feel cared for. And the industry evidence is even more compelling than that. McKinsey's series of 3 studies undertaken in 2014, 2018, and 2020 across 15 countries assessing the business case for diversity demonstrated its link with profitability with a higher likelihood of outperformance with ethnic diversity than even gender diversity. So how could we achieve equality in the NHS? Get to know the facts and start busting these myths and act to address the challenges. We all need to take responsibility, white and BME people. We need to lead the way in establishing a greater care, compassion, and humanity towards all staff and towards our colleagues. We need to develop sensitivity to clinical practice, which may be inherently discriminatory, as some new technologies have been identified to be. We need to challenge the inequalities in career progression and attainment in the way that Professor Nishan has highlighted. We could start by helping to embed the MRES and the induction program, which I hope to launch.
Okay, welcome everyone to the launch of BAPIO Training Academy session. I would hand over to Professor Stinker.
Yeah, thank you, Simon. So it's a pleasure to welcome you all to this exciting BAPIO Training Academy session. It's the last session before lunch, albeit virtual lunch. The session is about showcasing the work BAPIO Training Academy has done, and also trying to showcase what we are trying to do in future. BAPIO Training Academy was launched in 2015 to promote professional excellence. And we kept talking and kept discussing. And after a couple of years, our vision was always that we wanted to create something different, something unique. And I've always believed that true education is not about learning the facts, but true education is about training the mind to think. And we wanted to create something which can allow doctors to be innovative, creative, and imaginative so that they can become leaders of future health systems. And this is the principle we have adopted for both our UK and international courses. And can you have the presentation, please?
Hospital of the UK. So when we have IMG or other doctors come in any hospital, they have one-to-one mentor support. At the same time, we're bringing to get more leadership, more leaders in our committees. So starting leadership course. I know there are lots of us who are very interested in research. So very interesting basic research course will be coming, which run for 6 weeks. And all participants will have access to one-to-one mentor for another 1 year. There'll be excited every Wednesday. We'll be having regular discussion of critical cases, and loads of other educational events will be oncoming. If any of you would like to join and contribute, please feel free to email us. But at this point, I'm not taking much time and handing over to Mr. Ashok Khandelwal, who is the Director of Operational for BTA. Ashokji.
Dr. Ashok, could you please unmute your mic?
Very different. But the most important thing is that we have also contained in that the MBA leadership program for health and well-being. So health leadership is very important aspect, so that we want these doctors, when they go back to India, they are the leaders and they provide the best possible care to the patients in India and improve the quality of care in India. We have got a couple of partners like Bipin Batra and number of hospitals I mentioned. So next slide, please. I think our greatest achievement, I would say rather Ramesh Mehta's and Professor Singhal's greatest achievement was working tremendously hard.
Goes well. So,
well, thank you for giving me some BAPIO joy this morning. It's a pleasure to join you all.
Thank you. Thank you. Now we come to the second part of our BAPIO Training Academy. This is something what we are trying to. So instead of me telling about what is happening in India, let's play this video. To healthcare facilities, but they do have access to smartphone and technology. So let us see next video. So let us how we can use the technology in healthcare.
Could you give me a summary of the case, please?
He had a neck rigidity, right side mouth division and left leg weakness, and also your right eye was also elevated to the right side.
Sure. So this man was brought in, 27-year-old, unconscious. He had weakness. For the past 3 years, we have solved hundreds of cases, acute and non-acute, almost all specialties in medicine. We're privileged to say that the turnaround time is less than 4 hours in emergency scenarios. And one of the emergency cases I remember is last year that came in from one of the hospitals in Aleppo in northern Syria. A child in coma was suffering from diabetic emergency, and they didn't know what protocols to follow. When they sent me a case, I was child walking. I think that was something that I will treasure with myself for life.
This is how it can work. Now let me introduce the man behind this, Dr. Wahid Arian, who is EM physician and has recently been appointed as WHO digital expert and has founded a charity in the UK, Teleheal Charity. Over to you, Wahid.
Well, thank you very much for having me, Professor Singhal and the entire BAPIO team. It's a really great honor. I've always dreamt of collaborating with BAPIO and with my Indian brothers and sisters. So I think the opportunity is here now. Teleheal, I founded in 2015. First of all, Teleheal is a platform, a telemedicine platform, doctor-to-doctor. Teleheal is a platform, a telemedicine platform, doctor-to-doctor consultation. Through which volunteer medics in the UK, in the US, Australia, and Canada, they provide advice to their counterparts, to their medics in low-resource countries and conflict zones who may not have access to specialist care. And we use simple technology on our smartphones. In our spare time, whenever we have a moment here and there, whether it's in the office or whether it's at home. And because of the program is doctor to doctor, it kind of like overcomes many of the clinical and digital governance issues. Of course, there are many challenges that I'll come towards the end about it. But the reason why I set this up in 2015 in Afghanistan was to give back to the country where I was born in war, for 15 years suffering from the misery of conflict on one hand, from suffering from tuberculosis, malaria on the other hand, and not having any access to specialist care. And that sadly has continued till now. People go back to either Pakistan or to India, even to get a diagnosis. United Nations and the Rotary international organizations, because we do bring the communities together. So behind all this, although clinicians are saving lives and they're enhancing education, but they're also bringing all these communities together from across the globe, and that is the magic behind all this. When it comes to India, my first time that I went to India was actually my second time was to take my mother. She had a mass in her abdomen in Afghanistan. We couldn't even get to the bottom of that diagnosis. So I brought her back from Afghanistan to the Mahatma Gandhi General Hospital. Thanks to the BAPIO collaboration and to contacts there. They looked after her extremely well. But what I also noticed was that there was a huge queue of people coming from the remote communities to get some sort of a diagnosis, not necessarily cancer, but in many other specialties. And I researched more about that, and I figured out that actually it's not just Afghanistan and India, which is a huge global power, but still it has a population of 1.3 billion, and many people they reside in remote part. I had contact with Professor Singhal before, and then thanks to himself and to other BAPI leadership that we started discussing how we can collaborate and bring in all the lessons that we've learned along the way, the digital health lessons in Afghanistan, to collaborate with BAPIO. So you, the experts, can provide that expertise using simple technology to your counterparts, to the physicians in remote areas in India. And of course, the teleheal program that Professor Singhal has kindly introduced and that I'm talking about as well, it will take time. There will be challenges ahead. But the first part of this program, or the crucial part of this program, is the expertise that the BAPIO members have, the global expertise, the specialist expertise. That is the key component of.
Right, okay. That's better. Yeah,
Can you hear
yeah.
me now?
You can start
Can
now.
you hear me
Yes.
now?
Yeah, yeah.
Oh, so it tells you how much of a technologically in the same stage as such luminaries as Professor Ravikant and Dr. Aryan Vahid and Dr. Khandelwal and Dr. Singhal and of course Dr. Veena. We'll be, as PhD Chamber of Commerce and Industry, we are a 115-year-old organization, and we are present across 23 states and union territories in India. It will be really a privilege for us to associate ourselves with this opportunity to work on telemedicine, especially with such a prestigious institution as AIMS Rishikesh alongside Dr. Ravikant. I think we will be very, very happy to join, use our full resources, including our PSD Rural Development Foundation and PSD Family Welfare Foundation actively, alongside the strength of our diverse membership, to work as strongly as possible along with BAPIO on this project. Really a privilege and all power to your project, sir.
And be part of the change. Thank you very much.
Thank you, everyone. We should move on to the next session. Thank you.
Okay, thank you. Thank you, Sanjay. Thank you.
Dr. Shah.
Correct.
I'm back. Sorry. Good afternoon, Arvind Shah. I'm a treasurer for BAPIO. Apologies for technical glitch. Welcome, Graham Crossley. He's head of development at Quiltus, and also Veronica Trotter, who has been working with hospital doctors for 19 years. And also glad to hear that she was born in North Middlesex Hospital. Quiltus are in partnership with BAPIO for a while, and we appreciate their support for 11 divisions of BAPIO. They support the educational activities across with BTA. And Quiltus also, if you are BAPIO member, they do provide special privilege for different advisors. And today, Graham is going to talk about the important issue of NHS pension. So here to you, Graham. Graham?
Thank you very much.
No.
And so thank you very much for inviting us to talk today. I'm joined by my colleague, Veronica Trotter, who's one of our financial planning consultants. And she's just going to quickly sort of go through a little bit about who we are. So over to you, Veronica.
Quarter are quite a large organisation. We are a FTSE 250 company, and it is our intention to be the largest professional financial services company in the UK. And you can see there.
Thank you, Veronica. So going to go through McLeod and then on those annual allowance areas. So the one thing I'm going to ask the audience, as we're sort of all a bit new to this tech, is that we have this great feature called polls, which you might see on the right-hand side of your screen. As part of our ongoing agenda to try and improve the situation for NHS pension members, we're gathering information to help in our conversations with the government and NHS Pensions Agency. So throughout this presentation, can I ask you to have a look across at those polls and answer some of those questions to give us that sort of help and understanding? So a little bit of background then on McLeod. So this started back in 2011 with the Hutton report, where there were proposed retirement. And what they're looking to do with McLeod is to actually remove the discrimination that was caused by this transitional protection. So you're going to get a choice, and this will be for all members in scope, to determine whether or not you want your NHS pension benefits in the old 1995 or 2008 scheme, or in the 2015 scheme, and that's for a period of time called the remedy period. So that's all the benefits that you accrue between April 2015 and April 2022. That's the consultation. So the first is immediate choice. So you'll have an exercise very similar to the pension choices exercise, where you'll have to fill out a form that says, I want this pension. Or you'll have deferred choice underpin, which basically means you get to choose when you actually take your benefits or when you retire. Now, if the government goes down this deferred choice underpin route, or DCU, everybody will initially be moved back. Tax liabilities may have decreased all the way back to 2015. Your carry forward will remain unchanged for the tax years prior to the last 4 years, but the government will compensate you for any additional annual allowance charge caused by that restriction. I'm afraid it's going to be very complicated. The way that the government has set this out, it means that 2022-23 will be a very busy time readdressing all of your sort of annual allowance charges from 2015 to 2022. So I'd urge you, and it's worth £1,500 extra per year. But this is the reason why they're giving you a choice, because if you decide to work past 60, 62, and actually go towards sort of state retirement age, then at that point, the 2015 scheme becomes significantly better than the 95 scheme. To the extent that you could get a pension of in excess of £4,500 more in the 2015 scheme rather than the 95 scheme. So a lot will depend on your individual circumstances as to what's going to be the best route for you. If we look at the differences in consideration, so say, for example, you're now being asked to make this choice, choose the reform scheme, and then you'll get that extra £4,500 pension. But if the government introduces immediate choice, well, tough. You made your decision back in April 2022. You can't change now to the 2015 scheme, so you're going to miss out on that extra £4,500 pension from the 2015 scheme. And similarly, for the member who wanted to retire at 67, if it was deferred choice underpin, great, they can now decide, I'm going to retire last year, and we have now corrected over £600,000 worth of annual allowance errors. I'm going to cover off the main ones today. So the first one is best of three, misallocated arrears, and then something called inordinate pay. So for best of three, your 1995 officer pension is awarded based on the best of your last 3 years' pensionable pay. But up until June of this year, annual allowance statements used the latest year's pensionable pay, and that member saved £83,000. The last one I'm going to go through today is a bit of a niche one that we managed to set a precedent, because buried deep within your 95 NHS regulations, there's this final salary linking rule called the inordinate rule, which basically means that NHS pensions can restrict your pension if your pay rise is considered inordinate. So we went back to the Pensions Agency and said, well, look, if you can restrict a member's final award...
...to write off any scheme pays applications for 1920 tax year. So the year we're in now, it's really important to look at that, and we'd be only too willing to look at that with you. And as I said at the beginning, that is the very nucleus of your financial. We'll be more than happy to give you a free, no obligation, holistic financial planning review to allow you to do just that, see how your pension fits, and to make your pension come to life.
Thank you. Thank you, Dr. Shah, for chairing this session. Thank you. Thank you everyone for joining us after your very, very brief lunch break. This is an important session, and we want to talk about something that is in everyone's minds, everyone thinks about it. And here we are fortunate to have two top speakers who will take us through the challenges facing discrimination and equality within the medical profession. So our first speaker with me today, Mr. Jeet Mangwani, is my co-chair, and we have a couple of very good facilitators. And I would like to introduce our first speaker for this afternoon, which is Dr. Charlie Massey. He really, no introduction. He is the chief executive of the GMC, the registrar. He's had previous experience in NHS improvement, NHS litigation, and he's going to talk to us about the challenges that we face and how GMC is trying to tackle it. So, to talk to us about the challenges that we face and how GMC is trying to tackle it. So, over to you, Charlie.
Thank you very much, Joydeep, and thanks very much to BAPIO for inviting me to be here today to talk about the GMC's role in tackling racism and discrimination in the medical profession. It's always a delight to join you at these BAPIO conferences, even if this year we're unable to meet face to face. Now, the issues of racism and discrimination are, of course, long-standing, but they've been lent a new urgency by the events of this year. Those events have undoubtedly brought terrible tragedy and enormous challenge. But I do also believe that the pandemic has changed the conversation and has created an opportunity to make progress. And I'm absolutely committed that the GMC should play its part in grasping that opportunity. As colleagues will know, the GMC has been engaged with these issues for some time, and we've already taken a number of steps to tackle them. We've developed and massively ramped up our free training for international medical graduates to support their transition into UK practice. We've, over the last couple of years, built human factors training into our processes to make sure that the context in which doctors work is properly considered in investigations. And we've published our research to shine a spotlight on what drives higher referral rates from employers of Black and ethnic minority doctors. We're also not complacent about the potential for our own processes to be discriminatory. So we conduct regular audits to ensure those processes are free from bias. Engagement is critical, and I'm delighted that Iqbal Singh, who joins me today, has been such an excellent chair of the BME Doctors Forum, which the GMC hosts. And we recently established our wider twice as likely to be referred to the GMC by their employer than their white counterparts. And when you consider how much more likely employer referrals are to lead to investigations, that drives very significant disproportionality into our fitness to practice caseload. Now, that research pointed to many factors at play, including a lack of timely feedback, inadequate induction, and the presence of blame cultures, which create particular risks for doctors who are treated as outsiders. These are important issues that we need to address, working across the system. Meanwhile, as Ramesh mentioned right at the beginning today, BME doctors face an attainment gap that persists through undergraduate education and postgraduate training. Disadvantages faced in medical school can be compounded throughout a doctor's career and are demonstrated by persistent gaps in exam performance. Relationships with peers and seniors are crucial as a doctor progresses, but BME doctors report receiving less support and feedback during training and experience more barriers. And here again, the pandemic has upped the ante. Our recent national training survey found that over 80% of doctors in training said the disruption caused by the pandemic had reduced their access to the learning they needed to progress their careers. That's concerning enough, but what our data also showed were small but significant differences based on ethnicity. So we face risks that existing inequalities will be exacerbated. And these challenges in relation to employer referrals and differential attainment are multifaceted, and they require sustained attention to make headway. But just because something's hard doesn't mean that you shouldn't do it. And past experience tells us that what gets measured gets done. To really make an impact, we need to establish clear measures so we can found that 30% of SAS doctors have been bullied, undermined, or harassed at work in the previous year. It also showed that too many did not have the access they need to learning and development. And this research was vital not just in exposing the distinct experiences of this group, but also in giving us the data we needed to convince government of the need for legislative change. And I now feel, in setting the rules around the CSER and SEGPA process, that I hope will allow many more doctors to fulfil their potential. And this work is a reminder of the interconnected nature of healthcare. We don't control all the levers, and nor does any single organisation in the system. And that's why medicine, as they pervade all walks of life. To make real progress, we have to be targeted and intervene where we can make the greatest impact. We also have to put collaboration at the heart of our response. These issues exist across the system, so our solutions must be system-wide too. There's much left to be done, but we've already seen a real change in the debate. The focus now must be on maintaining that momentum and turning that debate into real action. I'm determined that the GMC will do everything it can do to effect positive change, and I'd also like to thank BAPIO for their commitment, and I look forward to continuing work together to drive this vital agenda forward. Thank you very much.
Thank you, Charlie. That's a fantastically brilliant presentation. Thank you very much. I'll hand over to my co-chair, Jeet Mangwani, to introduce our next speaker, please.
Thanks, Charlie. We've had the commitment for the last 4 decades to diversity and inclusion. But why we have failed is because the intentions have been there, but we haven't delivered the outcomes, and we haven't understood the lived experience of people from BA backgrounds. Next, please. We all know how many reviews there is a huge desire to address these issues. The number of NHS chairs in trusts, it has stood at 8%, 7 to 8% over the last 8 years, since 2012. The number of executive directors in the NHS has stood around the same numbers. We know it can be done. We know it can be achieved because the Appointments Commission, appointed in 2001, set a target for 12% BME non-execs in chairs and achieved that in 2011 before it was abolished. So we know it can be done, but we've gone back to that. Next slide, please. And we look at the RES indicators, and over the last 4 years, it isn't acceptable that 15% of our BME NHS staff feel that they have been discriminated or they've faced discrimination. And Charlie mentioned about the SAS doctors and the harassment levels, 30%, 29% for BME staff. The RES is a mirror. It has been very good as a mirror to organizations of where they stand. What we really need now is that we need to look at this mirror, awake our conscience, and address these issues. Next, please. And it isn't just, we will say, well, it isn't just in the NHS. We are a part of society. And these data, these figures tell you that in society, we have very similar lack of diversity at the top levels. Next, please. But I think that in health, we have a greater responsibility. Support them in terms of recognition and progression, and to support them when there are difficulties, local procedures, MHPS. Next slide, please. And we need to be able to take part, and we need to aspire and to be part of various national roles and national bodies, awards as well. And what is more important now is that the committees are beginning to reflect the workforces locally. And JS will know we've led in the Northwest in terms of our committees, and the committees are diverse and the outcomes they produce are diverse. And next slide, please. And the Cabinet Office has made huge progress. They said in 6 years they will deliver 13%, which is the UK BME population, 14%. The Cabinet Office appointments in 2018-19 were 13%. So if they can do it, we can all do it. And the other area, next slide please, has been the honours system. I mean, it's been a long struggle trying to recognize people with honours from BME communities. the introduction of public nominations, the introduction of public nominations. Next, please. Successive prime ministers have tried to tackle this problem, set up an independent selection committee because they were not giving us what we wanted to. And next, David Cameron started the Diversity and Inclusion Group, which now is the Diversity and Inclusion Committee. We changed that 2 years back. And the next slide, please. And one of the criteria for people who should get recognized by the current Prime Minister is those that have fought to tackle discrimination and have championed equality and fairness. And how many of our BAPIO members have over the years struggled and helped to address that. Next slide, please. So that does get reflected. I'm sure BAPIO or BEDA or the BME, it is something that each one of us is responsible for. Those of us who are unaffected need to be as outraged as those of us we are. And then we can all work together, and we can definitely, and I mean, it's good to see Charlie together, and we can definitely, and I mean, it's good to see Charlie here on this, then we can all achieve what we really aspire to, because we would like an equal and fair society. Thank you so much. Thank you, Joydeep. Thank you, Jitendra.
Thank you, Iqbal. That was really fascinating and the hard data that you produced in your presentation. It's definitely worth looking at, and it's thought-provoking on more than one levels. So if I can start with a question maybe to Charlie, and maybe to both of you really. To start with Charlie, I mean, the general feeling amongst the AME staff, particularly in the hospitals, is there's a lot of talk all the time. Yes, things will move, things will get better. These are being looked into, and I picked up a couple of comments in the chat as well here. It's about walking the walk. When is that going to come? So, I mean, you presented really well some of your thoughts and how things should move forward. If you were to put 3 big points up there to say this is how we should really be moving forward to bridge this gap, I'll be fascinated. I'll be really delighted to hear from you.
And I just got 1 minute to answer the question, please. Yeah.
Some culture change. So for 3 things, I would say having better and more consistent induction across the NHS, not just for doctors new to UK practice, but doctors new to roles. I think one of the things that Roger Klein and Diane Attawolligan were talking about when they did that report for us last year was how inconsistent that induction is. Second piece I would do would be around aligning the professional and system regulatory view about good leadership. Fundamentally, good culture, inclusive working environments comes from leadership, and that's both a bottom-up piece in terms of what us as professional regulators talk about in terms of the standards and expectations on our registrants, but it's also what the system regulators, the CQC, expect and hold systems to account about as well. And the third piece would be the legislative change that enables us to be as effective as we possibly can be. So taking away that glass ceiling that so many SAS doctors face in terms of not being able to get on the specialist or GP register, enabling us to keep more doctors out of our fitness to practice processes unnecessarily. So if I have to wave my magic wand and have 3 things, Jitendra, those would be the ones I'd go for.
Thank you so much.
Yeah, thank you very much. Yeah.
So I'll do some closing remarks. Then I know we keep on time. So
okay, thank you, Joseph.
So thank you, Charlie, and thank you, Iqbal, for fascinating insights into what we need to do, which Charlie is doing, and for Iqbal to tell us what we still need to, where the gaps are, and there is a lot of work to be done. I suspect, the last comment should be that diversity is not a tick box. It is not because there's 15% population, therefore there should be 15% representation. Actually, diversity brings out a lot of positive things. It brings out different viewpoints, different ways of thinking, and role models, as Iqbal said, are really, really important if we need to make our societies equal and for everyone to be aspiring to be good people. So on that note, a very big thanks to our facilitators, Sharan and Rajiv. Thank you, Jiten, for co-sharing it, and many thanks, Charlie and Iqbal.
Thank you.
Just let everybody know that there is a parallel sessions now. So we're going to be into the parallel sessions. Thank you very much.
Thank you.
Thank you.
Yes, so from very important announcement that from the next session onwards, we'll be running 2 parallel sessions. So I would like all the delegates to kindly use the stage button on the left-hand side to decide which platform or which stage that you would like to join. All right.
Thank you.
Welcome to session 3. This session will be chaired by Dr. Suparna Chakravarti, Joint Secretary of BAPIO Institute for Health Research.
Novus Challenges, New Beginnings and New Challenges. Our first speaker is Professor Russell Viner. And Professor Viner is the current president of the Royal College of Pediatrics. He's the professor of adolescent health at the UCL Institute of Child Health, and a pediatrician and adolescent physician working in young people with diabetes at the University College Hospital. And he also directs the Department of Health Obesity Policy Research Unit. Professor Viner's research focuses on population health, policy and health services for children and young people, with a particular focus on obesity. He has published over 200 peer-reviewed papers and is currently named on research grants with a collective value of more than £20 million. Over to Professor Viner.
Could you please unmute your mic, Professor Viner? Sorry,
if I could have the slides up. Can I move on to the second slide? So, the lockdown. All countries around the world had some form of lockdown for COVID-19. The idea of lockdown was to protect the most vulnerable in society, particularly the elderly and those over 50. And one of the issues is, what is COVID and what is the lockdown? And what have they done separately to children and young people? I'm going to go through what we know about children and young people and COVID, and also some of the impacts. Could I have the next slide, please? So, one of the things we think we know, and I'll explain this graphic in 1 minute. One of the things we think we know about COVID is that it very little affects children and young people. And that's absolutely true in a clinical sense. And I'll speak more about that in a minute. However, this slide is a heat map of prevalence of COVID in England in the second pandemic wave. The deeper the red, the higher the prevalence, and that's age on the left-hand side. And what you can see, and actually I think it's cut off here, but right even from September, beginning of October, we saw this second pandemic wave taking off amongst 20 to 29-year-olds and actually moving into older adolescents, and then into younger children, and then into older age groups. So it's been quite a different demographic to what we understood from the first pandemic wave. Actually, the truth is, probably the first pandemic wave had the same demographics. We just were not testing. We weren't testing populations, we were only testing symptoms. And around 80% of children had no symptoms, therefore we missed it. Now, so there is a lot of prevalence in children and young people. These are data for England, but the same is true of all countries across the world, we believe. Can I have the next slide, please? However, what we know is that severity, when children and young people get COVID-19, they get it at a very low severity if they get any symptoms. This is a graph of hospitalizations and deaths in England from COVID-19. And the great majority of those 25, the tiny number I spoke about, and yes, any death of a child is one too many, but the great majority of those 25 were those who probably might have been carried away by any winter virus. So COVID-19 in general affects children and young people very little. Next slide, please. The one exception to this is the new multi-system inflammatory syndrome we call PIMS-TS, which appears to be an immune overreaction to COVID-19 infection and presents 4 to 6 weeks after the initial infection. Again, this was something that was discovered very much in Britain and named first in the UK, and I think is a testament to our joined up medical system. The good news is, again, it's very, very rare. We probably saw around 200 to 250 cases from the first pandemic wave. We are starting to see a few from this pandemic wave. Next slide, please. So what do we know? I'll jump over this slide relatively quickly. This is susceptibility. So we've talked about prevalence, we've talked about severity. The question, how much do they catch it? There's some data, I've been involved in some of this research, that suggests that children under 12 are around 50, however teenagers appear to be as likely to get it or as susceptible as adults. And some of that high prevalence we saw in teenagers comes from them having susceptibility that's similar to adults, but very high numbers of social contacts. They meet other young people a lot. And next slide, please. One of the big unanswered questions about children and young people is transmission. We know that they can catch it. Even when they're less susceptible, the high numbers of social contacts they have can drive quite a high prevalence of infection. However, infection almost never translates into severe disease. However, do they pass it on? And do they pass it on to other children and to other adults? Could I have the next slide, please? But the real issue for children and young people is collateral damage. Collateral damage is what we talk about in warfare when civilians or people around the actual target of the action are killed. And that's what children have been in this pandemic wave. And even UNICEF, United Nations Children's Fund, says children risk being its biggest victims. If I could have the next slide, please. I don't have time in this talk to go into all of the different data on this. And I'll put some of the data up there, and I'll come to that in one moment. Very early in the pandemic, and we saw this in the UK, but right across Europe, and I'm certain for other countries as well, though we didn't have data, we closed down our children's services. We redeployed workers in child health, paediatricians, paediatric nurses. We also redeployed health visitors, social workers, and a range of others. And what we saw were delayed presentations and harm coming to children because we had closed down children's services and we had closed down the protective net that countries place around their children. So that was something we recognized very early on, and in the College of Pediatrics and Child Health we worked very closely with government. An increase in non-accidental injury or child abuse happening in pressure cooker families that were locked down in the first pandemic wave. We know that children are getting less exercise, they're sleeping worse than they normally do. That was during their first wave. And thirdly, we have little data about what they're eating and how they're eating. So we potentially have a range of harms coming through. Can I have the next slide, please? I'm particularly concerned about young people, teenagers 15 to 24. They have all of those harms I talked about before, but they're also, the older young people, they missed out on educational transitions, and also many of them are in the workplace. And it's young people who are the most vulnerable in terms of employment. They're the most likely to be furloughed, the most likely to be dismissed, the most likely to be financially distressed during this time. They've also been blamed in many senses by people for the second pandemic wave. There's been a whole range of issues there. Could I have the next slide, please? We have lockdown 2.0 around the world and upon us now in England. There's a song about this, which many of you may know about. One of the key things about lockdown 2.0 is that schools have stayed open. So government has heard, and well done to governments. And this is across the UK, but you can also see across Europe and other places that governments have recognised that schools need to stay open to stop the collateral damage. We also need to make sure as we come into this pandemic winter that our children's services are not stood down, that children's workforce is not redeployed, and that the health visitors and other parts of the protective net are not stood down. This is not because we don't want to help with the adult. If we spend all our money fighting COVID, there is only one place that comes from. That comes from debt, which is our children's future. All of the debt that the UK and other governments have racked up during this pandemic response is money taken from the future of our children and young people. And that is some children and young people. And that is something we cannot do whilst also allowing them to suffer direct harms. Thank you.
Thank you very much, Professor Weiner, for a very informative and instructive talk on the future. Do we have time for any questions?
I think we'll move on to the next session, and at the end of the sessions, if we have time, we'll take questions.
So our next speaker is Dr. Raj Patel, who is going to talk to us about healthcare delivery challenges in the virtual world. Dr. Patel is a senior GP leader in Greater Manchester. Since 2013, Dr. Patel has been the Deputy National Director of Primary Care and leads on the GP Forward View and the NHS Long-Term Plan. In 2019, he received an MBE for Services to Healthcare, and in February 2020, he was appointed to the Privy Council to the GMC. In this role, he oversees and assures regulation of doctors in the UK. Over to Dr. Patel.
Thank you very much. I'm delighted to be here. Thank you for that warm welcome. So, thank you. Could you go into? Yes, thank you. So that's who I am, and I've been in this role for about 7 years. And primary care is the main focus of what I've been doing in the last 3 years. But system redesign is the focus of NHS England, NHS improvement, and assuring quality is also something I've been involved with over the last few years. If we could go to the next slide, please. Darwin is often attributed with the phrase that survival of the fittest. You know, it's the fittest that survive. Actually, what Darwin said was it's the species that is most adaptable that is most likely to survive. And we have shown during this unpredictable time that we've gone into that what we can't do is look into a crystal ball and somehow guess what is in front of us, what we need to plan for. What we need to do right now is create systems that can manage no matter what you throw at them. Next slide, please. Who would have thought who would have predicted what happened this year? Could you press the next button, please? And again, and once more, just to get the third picture, thank you. Who would have predicted that this would be the new norm last year? We would not have guessed that we would all be living differently, we would all be practicing differently, and we, as the healthcare profession, would become the new heroes of the world. Next slide, please. And if you would press the next button again, please. Who would have ever realized that the phrase, "you're on mute," would become the new national anthem of 2020? And what we saw was a kind of dramatic shift from where we were before. Could you go to the next slide, please? So when we published the long-term plan last year, we set out £20.5 billion of extra investment into the NHS. And that was to firstly, as Russell was talking about, to first give a slowly changing. Hospitals, again, I think outpatient clinics are changing the way that people go in and out of buildings. We're now protecting people in a different way, and we're seeing people more and more remotely using remote care. Next slide, please. So let me just share with you the story of my father. This is my father. He is 86. He lives alone in Leicester. And this was him just 1 year ago, 13 months ago, where, and in February this year, he was able to walk 2 miles to the Indian grocers, do his shopping, get the bus home, and with the exception of having a weekly cleaner, he largely looked after himself pretty well. So just before we went into lockdown, I was about to go and get him because I didn't want him to isolate by himself. And what happened was I developed a high temperature and a persistent cough. I became unwell, and the second week I became even more unwell. Thankfully, I was rather shocked at what had happened to him. He'd lost about 10 pounds in weight over the 3 months that he'd been in isolation. You can see some marks on his forehead, which are healed abrasions. I've given him a haircut and a shave at this point and cleaned him up a bit. But he couldn't walk. He couldn't walk at all, and he was moving around the house holding on to furniture for dear life, and he'd completely lost his mobility. When I asked him why he hadn't rung an ambulance when he'd fallen, he'd had about 15 falls. He basically said to me, he said, look, it was only a fall. It was only a bruise. It was only a graze. It was only a bump. And he also said something to me which was deeply shocking, and that he said, and I've heard that if you go into hospital, that our people don't make it, our people don't survive. I've also heard that that hospital staff are being paid just to look after white people, and I was absolutely so angry at what he was saying to me, but again, recognizing that there is a part of our society that genuinely seems to believe all these false news that seems to come via mobile devices and social media. When I tried to get his GP to see him, it was very, very difficult. The GP initially said that they were only coming to see people if it was an emergency. When I talked her through his history, she was still very reluctant to see him, and when she found out I was a doctor, asked me if I would examine him, which I did. I had to draw a line when she said, would you examine his, can you check for lymphadenopathy and hepatosplenomegaly, at which point I said, no, I really think that somebody needs to see him and needs to see him in person. That was difficult, and we finally got him seen eventually at a falls clinic. That was cancelled 3 times due to all sorts of pressures within the NHS. He was finally seen, and then for all sorts of reasons, he had his various CT scans and his investigations delayed, and ultimately we managed to see him. But there you have it. This is kind of what happened to my father. Similarly, my own attempts to see my GP and to see a hospital, I've had to go through hoops and hurdles. So if this is the difficulty you and I face as clinicians, imagine the difficulties which are facing our patients and our population. So we wrote out to all hospitals and doctors and GPs in the summer, really saying, look, you have to reset services so that we don't put off people who are seeking help. So we don't put off people who have got symptoms of cancer, who have symptoms of mental health distress, as Russell was mentioning earlier. That we must tackle the pandemic, but at the same time, we mustn't miss this rising tide of ill health that is damming up behind the pandemic. So we have changed the way that we're all doing this, but we must maintain normal services as much as we can. The ratings or the crisis ratings of the pandemic were largely based on whether the NHS would be overwhelmed or not. And we still face a situation where the NHS could be overwhelmed, but at the same time, we can't let the plight of children, like Russell mentioned, go miss. We mustn't let the plight of people like my father, who can't operate the video device on his camera. He can't operate he doesn't hear very well. There are all sorts of, each of us will have a member of family. Each of us will have relatives relatives, each of us will have friends who've told you stories of how difficult it has been to get help during this time. Can I have the next slide, please? Yep. Okay. Yep. So if we just, these are the, I'm not, if we just go to this, I'll stop after this. I guess the questions we need to jointly ask after this is, how will care be accessed in the future? What do you want to keep from COVID? What do you want to do with your workforce? And ultimately to make sure that we don't create more inequalities, particularly digital inequalities. And we need to think about the long-term impact of COVID, as well as consider a country or a world where we have COVID endemic, or some other virus that comes to us at some point in the future. Thank you very much.
Thank you, Dr. Patel, for that very moving personal account and good questions for the future. We need to move to our final speaker now. And Professor Goddard has actually sent this pre-recording for playing. I'll give you a brief introduction of Andrew Goddard for those who don't know. I'm sure lots of you know who he is. Andrew Goddard is the president of the Royal College of Physicians. He's a consultant physician and a gastroenterologist at Royal Derby Hospital. Prior to becoming the RCP president, he was, for 5 years, he's been in the RCP medical workforce unit. And over there, he saw the professional and clinical affairs, both in the UK and internationally. And his main policy areas were workforce, healthcare funding, and future of general medicine. He was, as it happens, he's the youngest in 400 years among presidents of the Royal College of Physicians. And and Professor Goddard today is his topic. His speech is about evolving medicine in the changing world.
Good afternoon, BAPIO. I'm very grateful to Ramesh, Parag and Raj for inviting me to speak this afternoon. I'm going to give a short talk on evolving medicine in changing times, or in a changing world. So if I can share my slides. So a year ago, I gave a talk on what I thought the future of the NHS would look like, and I sort of went through Donald Rumsfeld's known knowns, known unknowns, and unknown unknowns. And the known knowns at that time were that healthcare will be busier, patients will be older and more obese and have more health conditions, and workforce will be different and insufficient. I also put up a slide of the 4 horsemen of the apocalypse. If I'm going to talk about evolving medicine in a changing world, I have to talk about the world and how it's changed according to COVID and what's happened to medicine in that time. Just worth us reflecting perhaps on where we're at within the UK, certainly, but can think about it for all countries. I'd recommend Our World in Data as a way to compare different countries. But you can see here that the United Kingdom is really following the same sort of pattern as France and Italy, although we're a little lower than those two are at the moment. Trying to explain why we have so many deaths per head of the population in the UK compared to other countries in the world is quite hard. Undoubtedly, our BME population is a part of that. You will all be acutely aware of the way that COVID selects out both men and people from a BME background. And we have all lost colleagues from COVID over the past year. I think that there is a clear relationship to the number of deaths in a population compared to the proportion that are from a BME background. And this is for UK data based on upper tier local authorities on the left and all local authorities on the right. I think the other thing that is unique in the UK and perhaps also in the United States and is happening elsewhere as time moves on is obesity. And obesity has been shown to be a big risk factor for COVID. So last year, talking about our patients being fatter, that's clearly relevant, and certainly is relevant to COVID. How we practice healthcare has changed radically and quickly over the past few months. We have learned to work in PPE, and very few of us would now ever contemplate seeing a patient not wearing PPE, and the challenges that creates for some people, and the barriers that creates in further barriers it creates in communication. I suspect that many of you have now had your box of 25 lateral flow tests and have started doing twice weekly tests, and hopefully that will reduce the spread of infection in hospitals. COVID has, though, allowed us to transform some bits of our healthcare service. And I talked last year about technology, and I think that when we produced this report, The Future of Outpatients, 2 years ago, we suggested 30% of outpatient appointments could be done virtually. Everybody rather laughed at us at that point. Simon Stevens took us at our word, and that became part of the long-term plan. But still, people were very doubtful. And then along comes COVID, and lo and behold, more than 30% of outpatient appointments are now held virtually. So it's interesting how a horseman like COVID can really affect rapid evolution and rapid change. There is a word for this, punctured equilibrium, which is based on the fossil record, that you'll see sort of things within the fossil record remain pretty static for many centuries. And then, bosh, something happens, and it happens very quickly. And we see that within medicine. COVID has also allowed us to learn a lot more about at-risk populations. And I come back to this, and this is from the open safety study, and you'll be aware of this data, but understanding which groups are more likely to become very unwell with COVID and sadly more likely to die. I think the use of data to begin to understand this in a rapid way was one of the positives of the COVID. We were able to upscale and develop new hospital sites, the Nightingale hospitals, and for whatever your views on that are, it showed that we can, and it may well shape how we run the final year of medical school from here on in. And hopefully in the new year, we, the Royal College of Physicians, together with the Medical Schools Council, will be launching our vision on that. Last year, I put up this slide as the things that make or break a trainee's happiness: workload, teamwork, education, and flexibility. COVID again showed this to be true, that in order for us to have a workplace where trainees want to be, and then we can keep them, retain them within the workforce, and they can develop as well as we are able to let them, that was proven by COVID again, where we had additional staff on the ward, either FIO1s, consultants, bringing people back from other settings out of research, for example. The workload dropped, the teamwork got better, there was more time for training, one-on-one, and there was more flexibility. So it comes back to the adage that at the moment we don't have enough doctors, but if we had more, everybody's life would be much easier. And isn't it amazing how quickly technology has advanced? So yes, my last four horsemen was advancing technology in the past.
Have we lost Subarna?
Yes, I think we've lost Dr. Subarna. I'm so sorry. Thank you for answering the question. We just had one quick question.
Mainstream and ensure that everyone can access the support and help they need to help them live their best life, whatever their medical needs. And we've called our vision a social revolution in healthcare. But I'm here today because I'm chair of the Academy of all the Medical Royal Colleges, the body that brings together every different medical discipline and achieves consensus on standards of care, education and career progression for doctors, and that speaks out on behalf of doctors on issues that affect us all. Now, with respect to the future of doctors and their careers, I want to suggest we now have to frame everything around the fact that we're living in this COVID-tinged world. When novel coronavirus 19 came into being, the world changed forever. It became a world where inequity and the social determinants of health have an even more tangible, visible and immediate impact on survival from infection. And while I'm at it, can I suggest we all drop that term post-COVID? As scientists, we all know better than anyone that there's not going to be a post-COVID world. There's just going to be a new normal where COVID is part of our lives and a world where we have survived the pandemic. So yes, we'll be post-pandemic. We will adapt, and our working practices will have changed at almost every level. So, as an Academy of Medical Royal Colleges, I like to use sustainability as a term that brings together our objectives. Sustainability of our planet and our responsibility as healthcare professionals, as citizens. And let's face it, environmental sustainability is a profoundly bigger challenge than COVID to our long-term well-being. But secondly, and core to our purpose, is that we focus on the sustainability of medical careers. And I'll come back to that in a moment, because that is the focus of this session after all. But thirdly, there's the sustainability of our NHS in the 4 nations of the UK. What will ensure that the NHS can exist for another 70 years? And that's a state-funded, comprehensive, universal healthcare. And for it to survive, I believe we need to rethink healthcare at quite a fundamental level. And what I mean by this is that we need to start with the citizen, the person in their own social and domestic situation, empowered to live their best, their healthiest and their most rewarding life, based in an environment that supports healthy, sustainable living. And that's involving communities, local governments, employment, and all those factors that we know impact on health inequalities. And then, when people need advice about basic health and well-being, they're informed about inequalities. And then, when people need advice about basic health and well-being, they're informed about where to go and how. They're digitally supported and enabled. They have accurate, timely, personalised information at their fingertips or available locally in a way that suits them. So that they're considered as a whole person with views and opinions shaped by their life course. And of course, when serious medical things are happening, the system responds to those. It communicates seamlessly with patients and within itself, and it does what it needs to do, but always remembering the whole person, so that the NHS and the care system doesn't treat people in parts for any longer than it has to. Now that's rethinking medicine in a summary, starting with the person, not the institution. Now actually, that's not radical. I think it's common sense, and I suspect that you all get this. But our training needs for the future need to reflect this. We need doctors who completely understand the need to be patient-centred, who understand the social determinants of health, the challenges of health inequalities, the challenges of digital exclusion. We need doctors that understand their role as leaders in the new landscape and understand how the whole system works, that have a great generalist background, irrespective of your specialism. Doctors who are equipped to supervise and support teams of other health and care professionals to ensure that patients get the complete care package that they need, one that fits them as a whole person. So future doctors also need to be exceptionally good communicators, translators if you like. And if we can all communicate better with our patients and work with them, if people feel valued, included.
Okay. So thank you very much, Helen, for that. And I do agree with you about having a more sort of a generalist approach, and we've become far too super specialists, and then we lose the sight of the patient and how they integrate into the rest of the community. So that's really helpful, and I really look forward to the questions at the end. So moving on now, it gives me great pleasure to introduce Professor Simon Gregory to you. Just a few words on what he's achieved to date, which is an incredible amount. He's Deputy Medical Director of Primary and Integrated Care Education for England. He also works as a jobbing general practitioner in Northampton, and he's also Honorary Professor at Norwich Medical School. He's also Chair of the University of Cambridge Military Education Committee. I might fall out with him, however, because he supports Northampton Saints rugby, and I'm a keen Tigers supporter, but I think he has a soft spot for Leicester as well. But anyway, I'm absolutely sure that his talk's going to be perfectly prepared, because he's also a regional scouts leader.
Sadly prophetic, but I think many things have changed in the in 2020. So if we can move on to my next slide, please. And I just want, before moving on to the future, Doctor, to understand or to call out what's happened of late. So the lack of PPE, I think, has been and lack of suitability at the outset, I think, challenged the compact that we as doctors believe we have, in that we put ourselves on the front line and at risk, and we go above and beyond. But we do so believing that we're going to be looked after. And that did challenge us. And I think that's affected how people are feeling. I don't think I can join a conference with so many friends from BAPIO, and Ramesh recently described me as an honorary member, which I hope I count as, but without recognizing the differential impact on colleagues of color. I say that term because I can't think of the right term at the moment, because some people like BME, some don't. But what I do know is that for many, this has been a matter of life or death, and we cannot go back, and we must work together now to address the causes of that. And the systemic racism is high among those. Then also the personal impact on each of us, and the family impact. I heard recently of somebody who moved out of their family home and lived in a travel lodge in order not to risk infecting their family. And sadly, some of that is already disappearing, and we can't allow it to. We need psychological safe spaces, and our juniors need beds, not a soiled mattress in the corner of the patient lounge. And nutrition. And I think nutrition is a major factor. And why is it that if you work in Tesco, you can get a hot meal at night, but if you work in the NHS, you can't? And we need to address that. Next slide, please. So consulting and learning changed rapidly. Some say the practice of medicine changed overnight. I don't think it did. I think it's how we apply what we do, actually, but I think we had those skills anyway. Some said that consulting, we've got to create the informal or recreate the informal. We've got to support each other, have buddies, use friends, but notice the person that nobody's looking after. And I have to confess, in our discriminating society, that is more likely to be someone whose face doesn't fit, and we've got to address that together. Beware of the hidden curriculum. The hidden curriculum of you've got to work longer if you're working remotely because people won't believe you're working. Beware of stigma, the hidden suffering, and of course the unintended consequences that this may exacerbate differential attainment, and we need to address that as well. Next slide, please. So I'm not going to go into detail on this slide. It's just to say that whilst we are currently dealing with the impact of care not being delivered in the acute phases, and yet we've still got the second wave of COVID itself coming, we've got these second and third waves of patient demand and impact, but also that fourth wave for both our patients, but also for us and our colleagues, of the psychic trauma, and this will run on for some years. Next slide, please. And I'm happy for these slides to be shared with people. You will note and I just want to point out, there's a new one added on today. When I was talking about environment the other day, people talked about the financial environment, and I'm particularly conscious there of colleagues that generously come to the UK to train, have to pay for PLAB, have to pay no end of extra things just to access the service. They're actually working in, and I think we've really got to make sure we look after everybody else. But the top three on my heptagon are really important, and I think we often forget. We often focus on the education, we focus on the expectations. We focus on the expectations. We're working together with BAPIO on addressing the equality and equity. But it's time that we ensured we properly engage with everybody again. It is also, though, time, I think, to celebrate excellence. We take type A people and then they're told they are competent, but that's the best they can do. That doesn't satisfy us. And actually, it's time to restore the joy in medicine. It's time to say that we enjoy it. Thank you very much for listening. I look forward to your questions.
Thank you, Simon, and thank you, Helen. Two really excellent talks. Do we have any questions?
Care that is based around the needs of the citizen, and enables us as the healthcare professional to give of our best but stay well.
Yeah. Simon, can I ask a question to both of you, actually, Simon and Helen? My question is this: we want to integrate more. We want to have a more of a generous approach to medicine as well. And we want and everybody is tending to have portfolio type careers. So why not do away with a lot of general practice and create consultants in general practice that can work accident and emergency a few sessions, 90% of the time in general practice, or vice versa? So I'm an ex-general practitioner and I enjoy going to my GP colleagues' surgeries and actually conducting diabetes clinics. I mean, is there a future in that? So you're doing away with this idea of a salaried GP or a partner, but you've got the same sort of animal that's fit for purpose.
In alignment with that, but that in time will take legal steps. So this generalist specialist register will go.
Yeah.
What I don't want to do is for us to confuse what Simon and I have talked about the need for greater generalism, as suggesting that everybody needs to be a GP. That is absolutely not what I'm suggesting. I'm reminding my physician colleagues, my cardiology colleagues, that actually being a really good broad cardiologist, my physician colleagues, my cardiology colleagues, that actually being a really good broad cardiologist, but remembering your respiratory medicine and so on, it is just as important as being the subspecialist in the anterior leaflet of the mitral valve, as Simon. That's a wonderful example, Simon. Because anterior leaflet of the mitral valve, as Simon. That's a wonderful example, Simon. Because our systems tend to celebrate and encourage and incentivize subspecialization at the expense of the other. Yeah. And we need both. This isn't an either-or question. Sorry, Simon, do you want to come in?
Thank you, Helen. Yeah.
So I would agree. I mean, general practice has been a specialty since 2007 in terms of training. I regard myself as an expert generalist. I don't see a hierarchy between consultants and GPs. And indeed, in my practice, on a Friday afternoon, it's now done remotely, but we had my GP colleague that is an expert on dermatology and general practice and a dermatology colleague from our local hospital. They work alongside in adjacent rooms. It also means I can nip in and say, can you just teach me about this or ask about that? We need to break down barriers, work together. However, I value the in-depth knowledge that my specialist colleagues have, that I can consult them about my patient when need, and I carry on handling the breadth and the uncertainty. And I think we've got to move more towards this respect. In Northern Ireland, the academy there have created a thing called Dear Colleague, and it's about the respect we show each other. And I think if we show respect to each other and we show respect to our patients, then that will be a huge leap forward in Futurum Doctrina.
Thank you, Simon.
Right, one last quick question. Being BAPIO, we have to ask about bullying and harassment by the BMA is shown to start in medical school and obviously leads to that journey of differential attainment later on. If you could both say one thing, how do we change that, to eradicate that one thing?
Okay, I'll a quick reply. Helen saying that we need to start calling it out. Those of us who are leaders need to, when we spot it, call it out. And sometimes we need to learn how to spot it. Sometimes we need to learn how to spot it. So for those who haven't done any training or haven't had any great insights on it, if you don't think there's a problem, you haven't learned enough. So get some training. And when you start spotting things, call them out. And I've had a couple of powerful experiences several years ago when I didn't call something out and lived to regret it. And subsequently, when I have called things out, what a difference it has made and the example it has set for others. Simon. One thing.
So we had a message to say we've got to stop. So I'm just going to say allyship, standing together. We've got to eradicate systemic racism and eradicate different.
Thank you.
Thank you both. Absolute brilliant presentations, and thank you for answering those questions really well. Thank you.
Absolute
pleasure.
Thank you.
Thanks for having us.
Thank you very much, everybody.
Thanks for the invitation. Bye.
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 Thank you so much.
Hello everyone, welcome to this session.
The development of Goldman Healthcare Link and is a founder director of Uganda UK Healthcare Alliance. Without further ado, I would pass on the mic to Professor Bain to give
activities in other economies. We also know, however, in the case of the NHS, that we've been absolutely reliant on that productivity and the fact that we remain one of the best universal health coverage systems in the world on our black and ethnic minority staff who have fundamentally been the cornerstone of our high quality healthcare delivery since 1948. We are aware that 10% of our current workforce are have had their primary and secondary education in other countries, either the EU or non-EU countries, and that the numbers of staff from non-EU countries are rising year on year as the number of staff from EU countries coming to spend time with us in the NHS has lessened. We heard that extraordinary figure from Charlie Massey earlier on today, that 61% of our current applications for working within the NHS are from black and ethnic minority backgrounds, and really for a middle-aged, middle-class surgeon such as myself, the challenge of trying to understand what we must do in order to create a more diverse, more culturally competent, sensitive workforce has really got myself, Health Education England and the team thinking recently. Next slide, please. And what I really want to do today is to talk about how we might think about future-proofing the NHS so that the mistakes that we've made over the last 72 years are not repeated. Next slide, please. So I'm an educationalist fundamentally. I'm a surgical educationalist. And so like all educationalists, and so like all individuals, when we are put under pressure, we go back to what we know. Next slide, please. And what I know is that education really is influenced by three things. The first is what we learn. And actually, in healthcare, what we learn is infinitely less important than where we learn it and who teaches it us. But these three things together are how we develop behaviours, how we integrate, how we act, and how we deliver on our skills and competencies. Next slide, please. Sorry, next slide, please. And this rather complicated diagram, I think, is the crux of what I want to say today. That we have spent far too long over the last 72 years focusing on learning skills and competencies. And if you look at this this ring of qualities, more and more and more engaged through partnership in health economies across the world in order that we can provide the right environment for the healthcare professionals of the future to develop those meta skills. Next slide, please. And what I'd like to do is to give you three examples of how that might happen. The first is a 3-minute video. Please play the video now, and that I'll finish off with the last two. Okay, it's obviously a technological difficulty. It did work before, so let me explain. So the first example I wanted to show you was of a partnership between South Manchester, the healthcare economy in South Manchester, and the post-conflict zone in northern Uganda. And the idea was some 10 years or so ago that ERIC would be developed between the two healthcare economies, and that we would place short and long-term volunteers from the Manchester health economy into the conflict zone to help with capacity building programs, and that we would undertake to have volunteers over the 24/7, 365 days a year to maintain that local continuity and sustainability. Over the course of the last 12 years, we've had some 650 colleagues from the NHS travel to northern Uganda, and a network of some 2,000 colleagues constantly communicating with healthcare colleagues in Uganda in an attempt to help with capacity building. Now, the reason that I wanted to give this as an example is because the impact that it has had on the healthcare workforce from the NHS is really quite extraordinary. That the offshoots of that particular health partnership have led to in Manchester and beyond. They've led to relationships between the first and the third sector in South Manchester in order to develop robust relationships with healthcare professionals and the population of northern Uganda. And perhaps most importantly, they have demonstrated how healthcare professionals may become more culturally aware and culturally competent of the challenges that face healthcare professionals, not just in Uganda itself, but also diaspora organisations in the UK. The second example of global learning is a programme that's illustrated by this slide and related to the session that Simon Gregory and Helen have just done previously. We were having trouble filling general practice posts in certain general practice training posts in certain parts of the country, and one of the ways in which we improved applications from UK graduates for these places were introducing a 4th out of programme year in South Africa, where those individuals were able to deliver primary care in South Africa itself. And what we noticed immediately is that the desire to understand healthcare delivery elsewhere by our new healthcare graduates in medicine was so great that these hard to fill programs were immediately oversubscribed. Next example, please. And then the final issue, which we talked about yesterday, was that if we are genuinely serious on becoming culturally competent and engaged in an equitable society, then we need to recognise that those healthcare professionals that come into the UK need as good a treatment, if not better, than our own healthcare professionals. And our Global Learners programme, which this year will see 800 new nurses coming from India into the reduce the amount of discrimination, to remove glass ceilings, to narrow differential attainment for internationally derived colleagues and black and ethnic minority staff. The core of this is by changing the way in which we behave and think as healthcare professionals through global learning, and that that learning is predicated on partnership. Thank you.
Thank you, Professor Bond. That was an excellent talk. I'll now pass on to my colleague, Chair, to introduce the next speaker. Thank you.
Thank you very much for that, Dr. Byrne. I'd like to introduce Professor Neena Modi, our next speaker. She is professor at Imperial College London and is a consultant of neonatal medicine at Chelsea and Westminster Hospital. She is going to talk about evolving priorities for women in the NHS, and currently she is president of the UK Women Forum as well. She has been president of the Royal College of Pediatrics. I'd like to hand over to Neena Modi, please.
Thank you very much, Rasika. It's always a pleasure to be with colleagues at BAPIO. Could I have my first slide, please? Thank you. I've been asked to say a few words about evolving priorities for women in the NHS, and I guess I should start by pointing out, if we could have the next slide, please, by pointing out that women, of course, are the cornerstone of the NHS. Women make up 77% of the NHS workforce, and you can see here on this infographic the distribution of the gender ratios for the NHS workforce. Approximately 6% of all female staff are doctors. However, 22% of male staff are doctors. 47% of very senior manager roles. And it's been estimated that we need about 500 more women in the top jobs in order to achieve gender equity across the most senior management structures. And if you cast your eye down this infographic, you can see some of the other breakdowns. But very, very generally speaking, let me re-emphasize, women are the cornerstone of the NHS. But the gender equity pyramid is inverted. Could I have the next slide, please? Now, we've heard a lot about some of the problems that there have been in the NHS, and one which hit hard at something that, as women, we all know about, but which was largely unsaid, was speaking up, listening up, and eradicating sexism. We know this is rampant in society at large. It's alive and sadly well in the NHS, and also in the BMA, and I'm delighted that the BMA has taken this seriously and is taking strong steps to eradicate any sexism within its ranks. My congratulations to the BMA in the way in which they have faced up to this challenge. They have recognised the problem and they are working hard to eradicate it. But I put this up to say this is one of women's priorities, to be sure that they do not have to contend with sexism in the workplace. Could I have the next slide, please? I've put up a couple of books in Daniel Mortimer here, and this is about men being allies. These are some wonderful quotes. First of all, Neil Dixon says, if men are to be effective allies, we need to support women and work with them and challenge assumptions and the status quo. And I'm going to come back to that point in a moment. And Daniel Mortimer said very tellingly, it's about recognizing that if men are part of the problem, and they are, then men should also be required to be part of the solution, which is why, again, I applaud them for making these powerful statements. And I also encourage you to read this report, which came from NHS employers, Men as Allies. I think it's got messages that absolutely cut across society. Could I have the next slide, please? But sadly, in the UK, and even more so globally, women continue to bear the brunt of inequities. Continuing violence against women. This is an infographic from the World Health Organization. Domestic violence, which we know has sadly increased dramatically during COVID. The brunt of problems falling on healthcare workers. And of course, there's the unpaid work that women continue to do the major share of in the home. Economic shocks, loss of jobs are affecting women disproportionately to men. Women's health has suffered, women disproportionately to men. Women's health has suffered. And of course, the education and schooling around the world of young women and girls, which was always something that needed to be fostered, has fallen back again. Women also bear the brunt of situations of conflict and migrancy. Next slide, please. There have been other issues that COVID has unearthed, so that, for example, we all know about the PPE problems that have beset the NHS throughout the COVID period. But of course, women bore the brunt of that as well, because PPE, never mind if it was sourced from unfortunate places, if it was not fit for purpose, but when it was available, it was really focused on a male workforce, not on a female workforce. We tend to be smaller and slighter than men. So another example of how women have been disadvantaged during COVID. Next slide, please. And BAPIO. I'm very fond of BAPIO, and I congratulate BAPIO, not just on this magnificent conference, but also on all of the sterling advocacy work that it has done over the years and is continuing to do in the future. But I would be remiss if, as a friend of BAPIO, I did not point out that it was striking that when I looked at the programme for this 3-day meeting, I saw 8 men as organisers and not a single woman. Next slide, please. It's 50 years. It has been exceptionally low in its take-up. Only 2% of eligible couples have taken this up. The bottom line is that if you do take shared parental leave, if a dad takes his share of parental leave, the family is going to be, and if the mum gives up her right to maternity leave, this family is going to be severely financially disadvantaged. In order to be effective and close the gender pay gap, requires that shared parental leave be offered at full or near pay. So my challenge to the NHS is, if you value your workforce, offer parental leave that is going to be beneficial. Next slide, please. So we at the Medical Women's Federation, together with our colleagues at British Medical Association and indeed in other organisations, would like to point out that attitudes to women need to change. Unconscious bias needs to be called out. We need to advocate. And yes, we welcome our support networks, which are doing fantastic, fantastic work to encourage women, support them and propel them forward. But we also need clear targets, and if necessary, we need legislation. Next slide, please.
Thank you. Do we have any questions to either of the speakers,
Yes.
facilitators?
I'll pick the question.
Could I ask Professor Modi, if women want to join the Medical Federation, how do we join it?
Just Google Medical Women's Federation and join us, please. We welcome all of you. We are a powerful voice. 77% of the NHS workforce is women, and our voice can be heard. Please do join us. Just Google Medical Women's Federation and you will find the registration details. And Dr. Rasika, I look forward to welcoming you to be one of our next members. That's wonderful.
Yeah. We have another question. How successful have the FTSUG been to escalate issues?
Sorry, repeat that question.
How successful have the FTSUG been to escalate issues? This was asked by Asha.
And what is FTSUG?
I'm sorry, I was only...
And we really thank from BAPIO and from the chair committee here and the facilitators.
May I ask a question, please? May I ask a question? I believe the BAPIO Women's Forum was established a little while ago. Is that correct?
Yes, there is a women's forum, and I think it's still in the kind of formation stages. We have formed quite a few new things recently, like the GP forum. So the women's forum is definitely there, and they did a big thing last year in the July conference, I think. But it's still in the formation stages.
Nina, I think you're on mute.
Sorry, Rustica, thank you for that. I was saying that the Medical Women's Forum would love to partner with the BAPIO Women's Forum. I'm sure that we can do some important work together.
Superb. I'll take that on board and carry it through. Definitely will be contacting you soon.
Right.
So if we do not have any more questions, we can conclude this chapter. If we do not have any more questions, we can conclude this chapter. And once again, thank you both speakers, Professor Ban, Professor Modi, and thank you facilitators for arranging and organizing this.
Thank you very much indeed. Thank you.
Bye-bye.
Bye. Thank you.
Hello everyone and welcome to our leadership session. I hope everyone's had an enjoyable day so far. So for our session we have our two chairs, Dr. Muralidharan, who is a consultant and head of service for diabetes and endocrinology at King's Mill Hospital, and Dr. Jyoti Srinivas, who is a pediatrician and deputy director of medical education at Milton Keynes Hospital and vice chair of BAPIO Women's Forum. I'd like to invite Dr. Jyoti Srinivas to chair the session. Thank you.
Thank you. Hello, everyone. Welcome to day 2 of the BAPIO annual conference. We are almost towards the end of the session today. We've had some brilliant sessions and speakers. For this session, we're going to be talking about the leadership perspective. To be led or not to lead, is this our destiny? And for this session, the topic will be on leadership perspectives and aspirations. So first of all, the first 2 speakers will be introduced by Dr. Muralidharan. Over to you, Murli.
Hello, everyone, and welcome to the session. I would like to introduce everyone, and welcome to the session. I would like to introduce our 2 young speakers. One of them is a young. Introduce our 2 young speakers. One of them is a young trainee, and one of them is a young nurse. Dr. Arif. Anusha Arif, she is a first-year IMT trainee at West Yorkshire, and she is talking about a junior doctor's perspective on leadership. So this is more about the aspirations and how we can achieve our full potential. All yours, Dr. Arif.
Thank you, Dr. Muralidharan. Can you hear me? My name is Anosha. I'm going to speak about a junior doctor's perception of leadership. I am a first-year internal medicine trainee, so that makes me the dead bottom of the food chain, and that's the perspective that I'm trying to share. And I know this is very cliche, but I'd like to start the presentation with a quote, please. And just to keep the feminism running, I've chosen Eleanor Roosevelt. Can I have the next slide, please? Roosevelt? Can I have the next slide, please? So Eleanor Roosevelt defined a good leader as someone who inspires people to have confidence in the leader, whereas a great leader inspires people to have confidence in themselves. Can I have the next slide, please? What makes a great leader? Now, I've only been in the NHS for a year now, and before I got here, I was in a bubble about leadership. I thought it was all about the power that you carry around, the influence that you have, your fancy suits and your barista coffees. But the system really changed that view for me. There's an enormous force of potential in the system when it comes to leadership. And there's a huge dynamic between... Can I have the next slide, please? Now, coming to the second part, how we aspire to be future leaders. I didn't have to do much background homework on this aspect because the Forbes magazine had already done it for me. A few years ago, the Forbes magazine ran a campaign with a lot of inspiring leaders where they asked around what their modus operandi was or what their USP was when it came to leadership. And the conclusion from that campaign was everyone's technique falls into the following 7 I's, which they call the 7 I's of leadership. Now, they're pretty self-explanatory, but I'll just run through them. So, great leaders identify their goals, illustrate their competence, and it's invest time. We don't have a leader yet that's invented time. It's invite ideas, investigate options, intentions, and improvise as needed. And this is what all of us are aspiring to do eventually in the future as well. Thank you. I just want to pass on to Kulsum now to hear a junior nurse's perspective on leadership. Thank you.
So before we take questions, can I introduce Kulsum Patel, one of the Band 5 nurses, at Leicester Royal Infirmary. She's recently qualified, and
the role that a leader can take in creating change, and in essence how much of a positive light it can have on patients and their outcomes, which at the end of the day, that is the goal that we want to reach. We want to make sure that the patients have a good and positive journey, and at the end of the day they're our main person within the NHS. So within the NHS, the common goal at the end of the day is for patients and to ensure that they receive the best possible care. So I personally believe that a good leadership, it directly is for the outcome of good patient care. So it doesn't simply have to be from senior leaders, so it doesn't necessarily have to be like from the chief heads of nurses. I think leadership can happen from all aspects of healthcare. So whether it be a junior band 5 nurse or coming from the most senior consultant on shift, I think positive change can happen regardless of whether it's someone junior, whether it's someone senior. So I think leadership is about inspiring, and through that inspiration, I think that's where change can happen. So I just wanted to give a little bit of an example about leadership and during this COVID time. So when I mentioned earlier, I am quite a junior nurse, qualified in December, and I know the pandemic, the first wave hit in approximately March or April time. And during that time, the ward that I work on, so in acute medicine, we did get a big surge of COVID patients that required higher level of respiratory support, so things like CPAP and an IV. And this wasn't an area that I was very familiar with, so I didn't have a lot of exposure to caring for such unwell patients in my training. So this was a big step for me as a qualified nurse. But as a junior nurse, working during a pandemic, I did have to take a big step into this, but I could not have nurses that are coming through during this time as well, and hopefully teach them, and that can essentially go on for further generations. So I think having that transparency, having that positivity, and having having such a good environment around you, that's how change can happen. I just wanted to draw back on one of the assignments that I did on university, which was regarding change within the NHS. So my assignment, it was done on mouth care with stroke patients and implementing a tool to ensure that it's done within patients in an acute setting. So a simple nursing act as mouth care, which is done day in and day out. A study was conducted where different leadership styles were implemented. So some of them took on some leaders took on a very nurturing approach. So some leaders took on a very nurturing approach and a very teaching approach to creating that change of mouth care within a stroke setting, whereas others had a very firmer approach. And the findings were very interesting in the sense that a simple
Thank you. Thank you. It was such a refreshing change to hear from a new doctor and a nurse who's recently qualified about what they think about leadership. And I'm glad you touched on a lot of good points, that you don't have to be in a senior leadership role to actually be a leader. Anybody can be a leader in NHS. So it was brilliant reflections. So what we'll do is we'll move on to our next speaker. That's Mr. Karamjeet Singh. I see that he has joined our panel now. Mr. Singh is the chairman at
Right. Good afternoon. Can you hear me?
Yes, we can.
I'm afraid I'm trying to work out how the camera should be working. Oh, let me. It doesn't appear to be working, I'm afraid. So I'm sorry for that. Okay. Well, look. Firstly, congratulations to Ramesh Mehta and colleagues at BAPIO, Biju Simon and his colleagues locally for organising this and the BINA inauguration. And it's a great honour to be invited. I have to give a health warning. I'm not a clinician. But I was just reflecting that if you think about the Artha Shastra, which was written 2,300 years ago by Chanakya, which is really a detailed manual on the science of living, he defined the qualities of leadership as intellect and prowess, association with elders, being righteous, truthful, enthusiastic, and disciplined, not breaking promises, showing gratitude, having lofty aims, and not being dilatory. And when he went on to define what a king, because in those days, obviously, it was mainly a male-orientated hereditary leadership, he said, in the happiness of his subjects lies the king's happiness, in their welfare his welfare. He shall not consider as good only that which pleases him, but treat as beneficial to him whatever pleases his subjects. So there you have a concept of leadership, which is actually about the servant leader and actually thinking about the welfare of others. And I think that is a very contemporary perspective of what leadership should be about. He was only out by 3 years. It took another 17 years. He said, my advice to you is look outwards and explore other avenues. So during the next so years, I actually had 5 different roles in different organizations as an academic researcher, as a community worker, as a senior investigator in the then new Commission for Age Equality, as a senior personnel officer in a large local authority, as an assistant chief executive in another large local authority. Before, in 1987, I took up my first national role. So my point there is that actually being flexible, looking outwards and exploring other avenues is another aspect of leadership. I think my third reflection is that during the last 7 years, I've sometimes, in a professional sense, there have been occasions when I've been disappointed. So the theme there I want to flag up is the issue of resilience and how important that is. Now, I have had well over 20 different roles in my. What are the levers and possibilities that you have to try and change it? Thinking about the learning that you get from that perspective. And I can say, for example, that in one of my roles, I was a UK electoral commissioner for a decade. And in that role, I had the pleasure of observing 4 Indian elections as a guest of the Indian Election Commission. And I learnt a lot. So I think that being in different settings, you can learn a lot. For me, it's a tremendous privilege to chair the University Hospitals of Leicester. Out of over 220 chairs in the NHS for acute, mental health and community trusts, there are only 10 of us who are Black or Asian or from other minority communities. And we have 16,000 staff. So we are probably the 5th or 6th largest trust, of which some 6,000 are BAME staff. Now, like many other NHS trusts, the senior leadership profile does not yet reflect the workforce, but that has to change. I do not believe in a heroic leadership model, that it is one person who actually says actions. One is that from my experience, organizations observe what their leaders do rather than what they say. I think my perspective would be that whatever, and the last speaker was saying, it doesn't matter at whatever level you are in an organization, you can be in a leadership role. But there's no doubt that whatever level you're at, your immediate supervisor has the most impact on your career. And then I think the third issue is the issue of mentoring. For me, the most powerful mentors were my parents. They had little education. They really faced the challenges of building new lives in this country and still remaining and keeping their roots in India.
Very interesting to hear about your leadership journey. And you've been one of the trailblazers. You know, it probably wasn't easier few decades ago as it is now to ask and be in these positions. And it's all about visibility. Seeing somebody who is the chairman of an acute NHS trust is very important for all other BAME people to look up to see if they can be something like you. So thank you for sharing all your points. For our final speaker, we go to Dr. Navina Evans. Almost all of us know about her and all her great work that she's been doing. Dr. Navina Evans is Chief Executive at Health Education England, and I will pass it over to Dr. Evans.
Thank you. Thank you very much. Good afternoon. I want to start by saying that I am thrilled to be here today talking at the BAPIO conference for three reasons, really. One, because this is my first time that I have the opportunity to speak at this conference. I hope it won't be my last. The second reason is I am now part of Health Education England, and I know that we in HEE have had a long and a strong relationship with colleagues at BAPIO, so it's a particular honour for me from that perspective. And thirdly, I want to just say, listening to Anusha and Kulsum, I am just so proud to be sharing a platform with you both. I just was bursting. I didn't think when I was a junior like you, I was thinking in the way that you were, so sophisticated. It's lovely. So let me start. So my name is Navina. I am Chief Executive at Health Education England. I'm also a child and adolescent psychiatrist. I was previously Chief Executive in an NHS trust, and before that, the Director of Operations at that same organisation. I have to say, when I became Chief Executive, which was only about 5.5 years ago, I was the first and only Asian woman doctor Chief Executive. And now, when I joined Health Education England, I am the only Asian woman Chief Executive of an arm's length body. Now, whilst that is something perhaps to be proud of, it is also something I reflect on as the fact that it's something to celebrate is also quite sad. And that is perhaps something we can discuss. What defines me? It's really important to say I am a woman of colour and I am an immigrant. And I want to thank you for inviting me to share my story in this session. Thank you for listening. I hope that through my story, we will have the opportunity to realize that we have we have a lot in common. And I hope that I can also contribute to a rich and fruitful discussion in the Q&A session. So, like many of you in this virtual room, I grew up in a Commonwealth country. In my country, we were very heavily influenced by all things British. My parents were both teachers, and they raised me and my brother to seek reward in service. Now I am just amazed that I find myself part of this 1.4 million strong family and movement towards providing healthcare for our people. When I was at medical school and through my specialty training, I was to today. For me, it was important to make sure that I'm always holding on to what really matters, to stick to the core purpose, and to hold on to our shared values. So, however difficult the situation I may find myself in, I keep making sure that it's important to return to three core beliefs, and these help every time without fail. And that is remembering what really matters, sticking with the core purpose, holding on to your values. It really does work. So during the preparation for this talk, I indulged in some, looking back at my past, and it was really quite fun. And I thought that I would mention that it would be really important to mention that I was really inspired by others, by leaders, and they weren't necessarily people with power, as we heard earlier. And the list of people who inspired me is really quite long. And during my reflections, I realized, I thought, what was it that they all had in common? These inspirational people, they shared one really special quality. All these inspire you as an individual and you for your development as a leader. I'd like to just point out at this stage, all of those people who supported me throughout my career, all but 2 of them were white, all but 3 of them were men. So they were completely different from me. I deliberately share this information with you because I think it's something to ponder. And I think there's a role to call out to allies who are different from us to help and support us. But for all of them, their most important qualities were their honesty in challenge and criticism for me, their firm encouragement, especially during crises of confidence, whenever I experienced that, and also when, like all women, I had and I still have, those imposter syndrome moments. The third thing about these people who supported me, they had genuine warmth and pride in me, the product. I also want to say something about barriers. There have been many, many barriers to overcome, which I'm sure I share with many people in this space. The barriers are too many to list, but I do want to say that it's important not to be defeated by barriers. And one way in which I try to think about that, and I would like to share that with you, is that I have adopted the sort of science of improvement and improvement methodology in how I work. This is a great way about using improvement science and methodology is a great way of thinking about problem solving and how to overcome barriers to success. And key to that is the use of data, the use of proper planning for change, the use of proper implementation and testing of your progress. And critical importance is understanding why it is the way that we all behave the way that we do. Understanding barriers to change, holding on to hope, holding on to kindness, and holding on to compassion. And it's also important that once you find yourself with that sort of little bit of leadership, responsibility, whatever your status, modeling the change that you want to see, the core part of how you do things. Now, as I come towards the end of my career, the other end, compared to Kulsum and Anusha, who are just starting out, I find myself with a particular voice because of where I am and who I am. And I've been thinking that I must use that voice that I have really wisely. I truly believe in the power of diversity in leadership at all levels. It's really, really important. I feel a sense of urgency to secure the right future for the healthcare of this country. And I think it is all of our responsibilities. I cannot, of course, like the rest of you today, speak without mentioning the impact of the pandemic on all of our lives. And I won't repeat what's already on all of our lives. And I won't repeat what's already been said. But the impact is not just on our health services, our own personal experience, our family and friends, but the impact is also on our values and our behavior. We are learning what kind of people we are and what kind of people we want to be, what kind of a society we want to be going forward. I believe what kind of a society we want to be going forward. I believe that we're in the midst of a movement for change in the culture of our NHS. I also believe we're in the midst of a movement for change in the culture of our communities. For all of us in this room today, we cannot choose whether or not to be part of the change. We don't have that choice. We can only choose how we want to engage in change. You always have to end with a quote, I agree. And I've chosen, of course, a Gandhi quote because when you come to leadership, he has so many. And the one that I thought really fits our discussion today is the one where he said, the future depends on what you do today. Thank you so much for listening.
Thank you. Thank you, Dr. Navina Evans. That was very, very interesting talk to listen to you about how you've come through and all your experiences for all of us to hear. And I'm delighted that this is your first BAPIO conference, and I'm sure this will not be your last one. I liked what you talked about, your father being a feminist, because I think it's important we have men as our allies, and they play a very important role in our lives. And also what you talked about, something we call it as lift while you climb. So when you are reaching up to higher positions, you help the others who are climbing up now to come up to higher positions. We do have some interesting questions coming up. So I think I have a couple for you and then one or two for Mr. Singh. If we start from you, Dr. Evans, the first question we had was, how do we empower our juniors to aim high?
I love that question. So I think I'm hoping that question came from a senior person. And I think that's where we start.
I think you're on mute. I think we've lost the thing.
Do you want to step in whilst he's coming back? On that question.
Yes, please.
Yeah. Very, very quickly, I can just say a couple of things. I think mentorship is really powerful, and I think that we have some schemes for mentorship, and it's not something that you can just do. And I think that we have some schemes for mentorship, and it's not something that you can just do. So I think it needs to be supported. The other issue is that we need to make sure that mentorship is accessible to everybody. And so mentorship programs, I think, are really helpful.
It is, yes. There is one, Navina, for you specifically. It says, what advice would you give to non-medical BAME leaders experiencing glass or concrete ceiling? What practical support we need to seek to flourish in our careers? And as a national BAME leaders, how would you influence this agenda?
Sure, gosh, that's a big question. That's a talk in itself. So I think that as a way to do that is really hard, but you can find the way. I like to think of, you can be like water, that you go in you find the way in all the little cracks and you get through somehow. And I think that that's a really important thing. The focus is wonderful for supporting one another. Oh, and one more. I always have a final one more, which is we get allyship. And if we have a chance in this to talk about allyship, I think allyship is really important.
Yes, thank you, Navina. There are a few questions coming up, quite similar ones, but there's a few comments going on about your background, about the Durga, that it matches very well, and where did you get it? It's brilliant.
Yeah. Isn't it gorgeous? I love it. It makes me feel. Well, I can sit here and I see it in the camera, and gives me a bit of sense of that have been in place. They work, and people people didn't let us down. So those are the things. But the other thing is, I think what's really, really important is how we look after one another. And I think many very senior NHS leaders, we need to shift our focus from maybe performance finance, all those things are really important. But the most senior people in organizations need to look after their people.
Absolutely. Absolutely. Yeah, I think it's the people that matter the most. Absolutely. Yes. I'll see if Mr. Singh can talk about his leadership during COVID-19. Mr. Singh, can you come in now? You might still be on mute, I think, Mr. Singh. Might still be on mute, I think, Mr. Singh. We have some facilitators.
Hopefully, once the pandemic is over, it's better.
But my question was, do you feel that if any new challenge is thrown at you like this, will you be able to cope more, or are you on the brink of that? If anything like this happens, I will go and look for another job.
I think it's definitely made me stronger. I think I feel like we're better equipped to handle anything that comes our way or any other changes, because I think COVID was such a big change and a different way of adapting to working. So I think anything else, it's going to be easier to adapt. It's made us definitely better equipped.
A question to Navina. It's an earlier question from our audience towards Mr. Singh, but I think you are equally qualified to answer this. How do you make the big trust boards accountable to make sure that the diversity, the trust board is diverse and inclusive?
Yeah. So there are a number of ways of doing that. I think the relationship between the chief executive and the chair. So I've been a chief executive, and I had a chair, and Karanjit Mr. Singh is a chair. They need to really put this high on the priority list. That's the first thing. The second thing is there are mechanisms, workforce race equality standard, freedom to speak up, staff survey. We all want to do the best that we can. So we need to use that kind of information to get the board to understand that this is really important. The third thing I'd say right now and going forward is the people plan. Right now and going forward is the people plan. We have the people plan, which has a very strong focus in there of equality and diversity and inclusion. And there is plenty of evidence. So I think through there's going to be an expectation that the leadership at board level really pays proper attention to the outcomes in this area. And then for the rest of us, we just need to make the noise and keep talking about it.
Again, following on that question, there was an earlier question from Kumarasamy asking. We talked a lot about medical team involved, but what about the non-medical BAME leaders, who seems to be quite rightly a totally neglected part? So, as a national BAME leaders, how do you influence this agenda? That was Kumarasamy's question.
Yeah, I think that's you're absolutely right. We have a lot of Asian or BME doctors, and our medical structure means that career progression up to a point is managed. But in nursing and in allied health and in management, it's much more random, and there's a lot of variation. So once again, I think it's about getting the data. Like I said earlier, it's really important to use data to as evidence. It's really important to offer that we have solutions for the whole of our NHS problems. And the third thing is actually stories. I think stories that we tell bring data alive. So having the opportunity to take those stories is another area which I think is work. HEU has to work really closely in partnership with service, okay? Because the placement and the training happens there, and HEE and service needs to work much more closely together. There's also a lot of variation, depends on which region, which trust, which team. I used to work in a trust myself, and the junior and took a real interest in the junior doctor issues. And again, I think leadership needs to be connected with what the junior. And I found what the junior doctors were saying they needed was actually really quite simple to deliver. So it's just connecting all the different parts that can come together to solve the problem. Again, I will say, if you use QI methodology and you think about improvement science in solving all of our problems, it really, really helps to make a big difference. But in one answer, I want to bring HEE much closer to service so that we actually work together to solve the problems. And there'll always be problems, so we must work together to solve them.
Thank you. Thank you, Navina. I think we've taken most of the questions. The other ones are all along the similar lines. I hope for the junior doctor and the nurse who presented today that you've learned something, you know, when you see somebody in a senior position, it's all about taking those opportunities, looking for things to do, and not shy away when you get something else, something new, and being curious, as Dr. Evans said, be curious and just look into what else is there to learn rather than just the curriculum and the service delivery. So I think we have only a couple of minutes, so we're gonna probably conclude the session soon. So I would like to offer a big thanks Dr. Anisha Arif, partners Mr. Karamjeet Singh and Dr. Navina Evans. Thank you for all your perspectives on leadership. And to my co-chair, Dr. Muralidharan. Thank you. So I think we've got a minute, but I don't think we have any other burning questions, but there are lots of thank yous and lots of nice comments coming through. So please have a look. But yes, thank you very much, everyone, for contributing. Thank you. Bye.
Hello everyone. Thank you all for joining us in this session. We have on stage Dr. Jackie Saxena, who is a registrar in obstetric and gynecology department at Leicester Royal Infirmary Hospital, to deliver vote of thanks. Over to you, Dr. Saxena.
Thank you. Thank you for inviting me and giving me an opportunity to be a part of the BAPIO organization. I'm very thrilled and excited to be here. I am grateful to all our highly skilled and intellectual speakers for the exciting talks today, and also to fill us with more insight into the topics which we have discussed today and have learned many different points. Especially I enjoyed the talk on narrowing the gap by mind the gap and progressing to mend the gap, and all the contributions and the work that BAPIO has done to narrow the gap with the racial and the gender inequality at all different levels. I also enjoyed, and thank you for sharing the platform for the training initiative academics and the leadership, where I was really fascinated by all the personal experiences by my junior and the senior colleagues, which has motivated me further, and I hope many others to be involved and contribute to the BAPIO organization. I would also extend my thanks to all our delegates who have contributed their time and becoming a part of this conference today, and for the 3 days. I am very thrilled, fascinated, and motivated, and would like to thank every member and every delegate of this organization to make it an incredible, wonderful, and excellent organization which has held our Asian community and the other ethnic communities to work in the NHS.